To the January Oregon Health Policy Board meeting. We'll get started in just a few seconds here. All right, well, welcome everyone. Again, it's nice to see you all. It's nice to see my fellow board colleagues. We'll go ahead and get started with our meeting. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host. All materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. We will go ahead and get started with a roll call. Tara, can you please help me out?
Yes, absolutely. Good morning, everyone, and Happy New Year. I did hear before the meeting, Jessica Gomez will be excused today. She can't make today's meeting, and we know Melina Moran will join us about 10 a.m. So with the other members, I'll go through roll call alphabetically. Oscar Arona.
Present.
Ebony Clark.
Present.
Kirsten Isaacson.
Good morning. Here.
Brenda Johnson.
Present.
Bill Kramer.
Present.
Sandy Sampson.
Present.
And John Santa.
Here.
Great, thank you. We have 7 of 9 members present for a quorum.
Thank you so much, Tara. All right, well, happy 2023, everyone. Last month, I spoke about the agency and state being a place of transition. Today, I'd like to amend that language and say we're in a place of opportunity. With new agency and state leadership, we have the ability and responsibility to think in new ways, try new things, and hopefully make new mistakes. I look forward to working with my board colleagues and OHA leadership to take advantage of this opportunity. I want to welcome James Schroeder and Chris Kautz to OHA. The board and I are very much looking forward to working with you in your new leadership roles. Please let us know how we can support you in your new roles, and we look forward to hearing more from you later in the meeting. Also, this weekend, I read some really wonderful news. I read that our very own board colleague, Ebony Clark, has been appointed to serve as OHA's Behavioral Health Director by Governor Kotek. So congratulations, Ebony. We're excited that you are going to be able to bring the board's lens, values, and background as you approach your new role. We also look forward to working with you in your new role. And of course, let us know what we can do to support you. We're looking forward to working with the new state leadership during the 2023 legislative session. We're also going to be initiating planning for our own OHPB summer retreat, where we'll focus on updating the board's short-term priorities. And after more than 2 years, we're going to bring back the OHPB out-of-area meetings later this year. I'm looking forward to strengthening relationships between board members this year, as several of us have yet to meet in person. So for today's agenda, here's what we'll be covering. We'll get to meet and hear agency updates from Chris Kautz, OHA Deputy Director, and also hear from James Schroeder, OHA's Interim Director. We'll hear about OHA's work with the unwinding continuous eligibility requirements in Oregon. The Health Provider Incentive Program will present its proposed allocation request. Please note that the agenda item requires an OHPB vote. We'll hear public testimony. We'll also hear a summary of findings from the Healthcare Workforce Needs Assessment final report. This is also an agenda item that requires a board vote today. And finally, we'll get an update from the CCO 2025 contract procurement report that was submitted to the legislature at the end of December 2022. So before we go ahead and get started with those items, our first order of business this morning is to vote on the draft OHPB meetings from our December meeting. The draft minutes are listed as attachment. Kirsten, I think I saw your hand.
Yeah, I have one small edit to the minutes from the last meeting. Sorry. It lists approval of the prior minutes as unanimous. And I think, while I think that is what the vote happened initially, I later was like, oh, I need to change to abstention because I wasn't present. So
Thank you. We will make that edit. So I suppose, is that a motion to approve the minutes with that revision, Kristen?
yes, motion to approve with one revision.
Okay, motion to approve the December draft minutes with Kristen's revision from before. Can I get a second, please?
Second.
All right, thank you, Bill. All those in favor of approving the December draft meeting minutes, say aye.
Aye.
Anybody
Aye.
oppose? All right, any abstentions? All right, thank you so much. So let's go ahead and meet our new OHA leadership. So let's welcome our special guests today, Chris Kautz, Deputy Director, and James Schroeder, Interim OHA Director. We'll go ahead and get started with James introducing himself and then get an agency update from Chris.
I'm not sure James is on. He just texted me a moment ago saying today's his first day and he's still getting all of his electronics and technology set up. So I think I might roll first and see if he's able to hop on while I'm doing my overview, if that works for all of you.
That works. Thank you, Chris.
You bet. Good morning, everyone. I haven't had the opportunity to present before the board before, and I've been in OHA 5 years. They've kept me far, far away, but here I am today in front of all of you. So thank you for having me. I have had the distinct honor of being the acting director for 1 week from January 3rd to January 9th. Fortunately, all things seem to continue in good order going forward. Let's talk a little bit about what I have for you today. I know, unfortunately, James wasn't able to, oh, look, I think he just got on. So before I roll, let's check and see. James, are you there?
I am. I can hear you too. Can you hear me?
We can hear you. We can't. There you are. Oh, there you are. So James, I was literally just getting going. So it would be great if you took the opportunity to introduce yourself and do your piece first, and then I'll keep going.
Great. So good morning, everyone. A little hectic this morning as I am literally starting today. So IT's been setting up, my technology and computers and everything. So apologies for being a little bit tardy, but not too bad considering, first day. So first time actually seeing my calendar and all of that. So ask for a little bit of grace today as I'm trying to hit the ground running, it feels like. So I've met some of you I know in the past. I've presented to this committee in the past and, from a different role. But, briefly about me, right? So I'm a community health primary care provider. I'm a PA by training. Spent about half of my career in the community health center, FQHC world. A good portion of that was full-time clinical, and then transitioned to doing both leadership and clinical in that setting, primarily at the same FQHC in Southern Idaho. So that's really kind of my core base and value really comes from, that time of primarily being focused on patient care and hearing individual stories and experiences. And back then that was pre the Affordable Care Act. So while I've been a Medicaid, kind of leader and clinician for sadly about 27 years now, it's a much smaller portion actually of what we did, as most of our patients, over 50%, were generally uninsured. So just the progress right from my own history to where we are now, and thinking about 95% or so in Oregon being covered and more to come, is, kind of a great thing to have, experienced in a career, and really start to see that change. Not that we don't still have work to do, but what a big leap we've made just over that 20-some year, time period. Landed here in Oregon about 2008, started at Care Oregon. Really what their goal with me was to try to help them with their provider relationships. What I ended up actually working on was mostly access. So created a number of collaborative clinics with a number of the county health departments, found like the Rockwood Clinic, if you're familiar with that part of Portland, got Care Oregon to purchase it, and then had Lily and Shirley at the Multnomah County Health Department agree to operate in it. All of that collaborative stuff ended up leading towards forming a new clinic system, which at that time was Care Oregon Community Health. But we ended up applying for a 330 grant, and then changing the name to Neighborhood Health Center, which is a thriving organization in the Portland metro today. Then I spent about nine years with Kaiser, really trying to help them be ready for the Affordable Care Act. When I joined Kaiser, I joined in a national role to try to help all of their regions, they have 8 regions, take a more meaningful role in Medicaid or charitable programs. So we went from about 250,000 Medicaid members being served in the Kaiser system to over 1 million while I was there, and helped them build a lot of infrastructure and things to do that. And then came to HealthShare about 3 years ago. It'll be 3 years, or would have been 3 years next month. Really focused HealthShare on like taking advantage of the fact that we have kind of a unique thing in the Portland metro, where all of the players in Medicaid are really at the same table. And so how do we really make the most of that collaboration, which led into doing work in housing and other things. So I'm excited to be here, a bit humbled and recognize kind of the daunting task, but we have a lot of good base and foundation to build off of, while at the same time having some things that we really need to do well. And top of list for me is redetermination. As all of you know, that got turned off really in March of 2020, so almost 3 years ago. I think that's the longest time in history that redetermination has been paused. And we'll want to make sure that we land our 1.4 million Medicaid individuals well, whether that's continuing to be covered and served by Medicaid or OHP in Oregon, or in new possibilities through Bridge or Basic Health Plan or whatever is decided in the legislative session this year. Number 2 is the waiver. The waiver is a huge opportunity for us. We've been given a lot of opportunity there that a lot of other states would like to have. So we really want to make sure that we take full advantage of that. And I'm super excited about that. We can make such positive impact in our communities with the things that CMS has allowed us to do, which is really making social determinants real. We've talked about them forever. And this is a real chance to show what actually giving a benefited social determinant entitlement looks like, and how we can really change lives with that. So I'm super excited about that. And last but not least, of course, is our behavioral health system. And as somebody who works both as a military clinician still, so I still do that, and I still work with trying to help people get access to behavioral health services, and it's really hard right now. And I think that's true across the country, not in Oregon, but we just have a lot to do. We have, again, a good foundation to build on, but we do need to, make sure that we have a system that serves the needs of our communities and our community members, and we don't have that right now. So excited that Ebony Clark is going to be joining me, at Oregon Health Authority. It was an easy thing to, reach out to her to see if she would be interested in doing this. We've known each other for a little while, and I just have a ton of respect for her and her passion around behavioral health in particular, but a lot of other things as well. As you know, she's been at Multnomah County for a while. She started as a clinician and then moved into leading the behavioral health department of Multnomah County. And then, over the last just recent couple of years, she moved into the health department lead position. She'll be starting on the 27th of February. So just really excited for her to be joining. I know that all of you know her because she's been a part of this board, and sorry to be taking her from that, but very excited about the partnership that Ebony and I will have in working on behavioral health with the agency here. So lots of words from James this morning, but wanted to give you a little bit of intro to me, and certainly any questions, happy to entertain any of those. I think Chris is going to manage the OHA update, as I was like, oh my, that's a lot to ask, right? For me to be able to give an update after being here for a total of about an hour and a half this morning. So appreciate Chris for taking that on. But really excited to be working with all of you. And again, thank you. And, if you do have any questions, I'm certainly open to that. So, and I can't see Ebony, so is she here? So yes, would love to have Ebony, also make some comments. Unfortunately, on my screen, I can't tell who's here and who's not. So Ebony, if you're here, it'd be great to give you a moment to also kind of talk a little bit.
Thank you, James. Can everyone hear me okay? All right. So just for the record, Ebony Clark, pronouns are she, her, hers. I too am very honored and humbled, and being able to have the opportunity to be a part of such a significant and critical time for our state. While we have a daunting task ahead of us, I know that we can get it done. I'm super committed to this work just because, and I think that, my fellow board members have heard me say, while we sit around a table or around a screen, there are people out there suffering. And so the time is now. So James, thank you for your support and being a part of the selection of bringing me aboard. So just a brief, tiny bit about me. I've been in the field for about 25 years now, believe it or not. As James said, I started out as a clinician back in the day at LifeWorks Northwest, which was a nonprofit, which continues to be a regional nonprofit here between Washington County, Clackamas County, and Multnomah County. My specialty was child and family adolescent, and also working in co-occurring residential treatment programs for primarily African Americans and children and youth. And so have a long history of direct service, especially on the child family side. Stepped into leadership at Life Northwest, and I was overseeing all of the Multnomah County child and family-based services. Also started to support and oversee all of the culturally specific SED services. And then I stepped into a role at Multnomah County. I've been at the county for about 12 years and started my career at the county overseeing wraparound services, which, again, focuses on kind of that care coordination approach that's really consumer and client family centered on the child and family abuse side. Worked my way up, was promoted to deputy director and then behavioral health director. And as James said, most recently, for the last 2 years on the dot, I have been the health department director for Multnomah County, which includes public health, behavioral health, corrections health, and then our community health center. And so again, just super honored to be here. I'm sure that many of you have heard a little bit about my personal background. I, was born drug affected. I had heroin in my system when I was born. My mother went through one of the first grassroots residential treatment programs that really did cater to African Americans in the late 70s. And so, I get a lot of my commitment to giving back in the service-oriented work with just my personal story. And so I'm ready to get to work and work with all of you. I believe in being held accountable. I believe in the philosophy of really looking at how do we really start to continue to enhance how we are really consumer informed and led and centered in our work, not losing sight of the various core gaps that we really need to focus on in terms of our crisis continuum of care, in terms of those who are justice involved. I think it's important for us to not lose sight of older adults as well as children and youth, and then culturally specific. I could talk forever. I'm gonna, end my comments now, but I'm super excited to get to work. So thank you.
Congrats again, Ebony. We're so excited to see you in this new role, and welcome, James. Happy to have you be part of OHA leadership. So questions from the board or comments for James or Ebony before we turn it over to Chris? Brenda.
Welcome, James. It's great to see you. And Ebony, congratulations on your new role. James, I suppose my question or comment is directed to you around this board has been heavily involved in the work of health equity for the agency, both in terms of helping support OHA define its focus around this body of really essential work. So on day one, it seems fitting that you might give a few moments to speak to how you see this body of work evolving. And what I'm hoping for is a continued commitment to stay the course. It's such an important transition time for the agency, and we've done a lot of work and we have a lot of work yet to do. So if you could take a few moments on that topic, that'd be helpful.
Sure. Thanks, Brendan. Great to see you as well. Brendan and I, when I was back as an FQHC CEO in Idaho, it was when we first became acquainted. So, and thanks for the question about health equity. So one thing, and you'll see, so there'll be an open letter that goes out to the media this week. And what you'll see in there, Brenda highlighted, is like, here are the priorities, here's all this, but know that we're not going to move away from our focus on health equity and supporting, the 2030 goals. As you probably recall, right? So my practice when I was seeing patients were about 90% people that preferred Spanish over English. And they would drive for a long ways to come and see me so that they could have someone that they felt connected to both culturally and linguistically. So I have a huge passion around language access just as one piece of health equity, but I can reassure you won't see any divergence from that. I'd love to show you a visual. So one of the things that I established when I first started at HealthShare was there was a lot of talk about equity, but not a lot of action around it, or like, how do we make equity into our work, right? So it's not just a talking point, but it actually reflects how we approach the work and the outcomes that we're after. And we embarked on the first 3 months of developing a strategic framework, which showed that all of our work, the outcome goal is improving health equity, and that the 2 major areas that we wanted to focus on to achieve that, because there's a lot, right? But the 2 pillars that we wanted to most focus on is behavioral health and social determinants. And that's where the housing work sprung from. as well as our focus on transitions populations, in particular those being released from the justice system. So, and then the other component to that was that we were going to use a racial equity framework around our approach to health equity. Again, so the way I always talk about equity, Brenda, is that it's a journey. We are not there yet. We made some strides, and that is true for OHA in the state, right? So we're making strides and we're moving along our journey, but we still have work to do. So you won't see any lessening of that, and I don't have a good feel. I can't tell you that it's going to be more, right? Because I don't know exactly where the agency is, but it is a core value for me and always has been. So you won't see that change in any way. So
yeah,
thanks for the question, though.
Yeah, you bet. Thanks, James.
Ebony.
And I just want to piggyback also on what James said, and I want to also note that many of y'all know me, but I also believe that we have to take an equity approach and have a through line in all that we do. And I think that when I talk about equity, not only racial equity, where we think about policies and practices and attitudes that have these disparities because of one's race or ethnicity, but I also think about health equity that then gets at the issues of discrimination and poverty and other marginalized groups. But I think that it's important to think about racial equity, health equity, and then also geographic equity too. And so that's not lost on me, because I think about, the challenges and struggles that our frontier and our rural communities are grappling with. And so, those are kind of three kind of core tenets when I think about the word equity, so that we really can get to some real places of healing.
Thank you, Ebony. Any other questions or comments from the board for James? All right. Well, thank you, James, for stepping in on your very first day and sharing a little bit about yourself and your priorities. We're really excited to work with you and support you in this role. So let's hand it over to Chris for the agency update.
Great, thank you. So first of all, it's my understanding that you all like to know about leadership changes. And as you're aware, we've had key leadership changes, right? Pat, Steve Allen, our behavioral health director, thus Ebony coming on board, James coming on board. Also, Jeremy left a while ago, so we have the vacancy in health policy and analytics. Medicaid director is open, and Margie Stanton, who is currently the health systems division administrator, announced her departure in February as well. So James and I have said there are vacancies we need to fill, and we haven't gone any farther than that. We had chief of staff too. Don Jagger is leaving, and Yoni Khan is on board today with James as our new chief of staff. And so he is also getting oriented to the agency. James brought him over quickly to ensure he had some crossover time with Dawn before she departs. Wednesday is her last day before she heads off to the federal system to work with Rebecca Jones-Gaston on children's issues at the federal level. So that's a little bit about that. James and I have, with the rest of leadership, work to do around what's the plan going forward for the slots that haven't been filled by Ebony and Yoni and James himself. And so we'll go from there. Also, just a little bit, as obviously we have a new governor inaugurated yesterday. And there have been, she is starting to announce those that will be working with her in her office. To date, the only announcement in relationship to our organization is that Annalise Dolph will be the behavioral health initiatives contact in the governor's office for us. They have not named a health policy advisor yet. And then Taylor Smiley Wolf is the housing policy person. And of course, given the issues right now and the fact that the governor is putting out a state of emergency, one of her first actions was to create a state of emergency around homelessness. We will be working very closely, given the waiver opportunities that we have with the housing community, to see how we can come together with not only our two agencies, but a whole bunch of other agencies to try to address the crisis that is and continues. The governor has a very aggressive plan around this, and so lots of work to engage in and be done in that realm. Any questions on that before I keep rolling forward? Just checking. Okay. Then just into some of the numbers, so to speak. So how are things going in relationship to COVID, RSV, and the flu? Because right now they have been the trifecta this winter of events that have created, as we know, a crisis for kids and have been straining the healthcare systems overall. The upside, if you took a look at the numbers as I did before coming into the meeting today, is that it does look like hospitalizations and cases in general are starting to come down. Of course, we remain hopeful that that trend continues. Unfortunately, we hit a milestone, yet another milestone of over 9,000 deaths recorded due to COVID. And so, you know, it's still out there. It is still something we are working on a regular and ongoing basis now in conjunction with RSV and flu. It is keeping us on our toes, and we continue to bring in, as we can, coordinate with the hospitals and behavioral health providers and long-term care providers, clinicians from outside of the state to support the workforce as needed, as there are trends and spikes in need to provide care to those who are ill. So with that, let's, any questions about that? Good, then I will move on to healthcare market oversight, or HCMO as it is known to the group. So as you can imagine, we have completed the 30-day review of the Amazon One medical transaction, and it has been approved with conditions. So Amazon does plan to purchase One Medical for approximately $3.9 billion, and they operate over 180 medical offices nationally and 5 primary care clinics here in the metro area here in Portland. OHA has found that the transaction is unlikely, let me correct my language there, to substantially reduce access to affordable care, which is great news. And we do not anticipate that this transaction will result in increased prices. They have a small footprint in Oregon and serve just a small number of patients overall in the big scheme of things. The transaction is approved with the condition that Amazon and One Medical report information about the services they provide, the patients they serve, the quality of care, and any governance or organizational changes on a 6-month basis over the next 5 years. This is the first time that we have approved with conditions, and so we'll play that out as it rolls forward, this particular transaction. Any questions on that? There are more.
Chris, you had a couple of questions. I saw Bill's hand up first. Go ahead, Bill.
Yes, my apologies, I didn't see you.
That's okay. Thanks very much, Chris. It's great to see this healthcare market oversight program in operation. I was listening closely to the conditions But you may have said this already, but was there any condition related to price? I understand the conditions related to governance changes and so on, but were there any conditions related to price increases?
I'll have to look to the staff to help me.
Hi, Chris. I can fill in on that one.
Thanks.
Hi, Bill. No, the only conditions attached to this approval are the reporting.
Reporting about patients served and
Yes.
and governance changes and so on, but no reporting on prices even?
Correct.
Is that because it was determined that this was a very low risk?
Generally, yes. I think, and if you looked at any of the public comments that we received, there was a lot of concern about sort of Amazon entering this healthcare space and this commercial space. And one of the things that we looked at was One Medical is already a for-profit company in this space, and we didn't think that there was likely any chance of price increases coming from consolidation in the way that we might look for in other transactions.
So because as a for-profit, they would have already maximized their price, which might be unlike an acquisition situation, which they would acquire a not-for-profit organization.
Yes.
Okay, thanks for the clarification.
John.
Yeah, Chris, first of all, thanks for coming to OHA or OHPB this morning.
You bet.
And thanks for stepping in as transition director. And really impressed from a leadership point of view how the transition has gone and been managed. Thank you. I do have concerns about the Amazon OneMed transaction, especially as it relates to the decisions around cost and equity. I think that the policy issues around those aspects are robust. I don't think this morning is the time to further pursue that. So I would ask that there be an OHPB, both educational session and board session in the near future to further discuss these aspects. Putting the decision aside, I think what's important is that we constantly, as Oscar referred to so appropriately this morning, be learning from these issues. And I think especially from an equity point of view, as I read what I've been able to read and absorb, which this is a very complex transaction, I think the equity implications are very complex and should be discussed in a public environment with the public listening. Thanks.
Thank you for your comments, and we'll coordinate as needed and necessary going forward. So with that, continuing on with more HICMO program update for you. There are currently 3 reviews occurring this month. Adventist Health's planned acquisition of Mid-Columbia Medical Center, Radia's proposed acquisition of Medford Radiology Group, and Care Oregon's planned merger with Scan Group. So once we've received complete notices, the program will begin the preliminary reviews and open public comments for each of those transactions, as we have now created a process for going forward. Also, please note in your packet, attachment 2.1, you will see all the work that the program did as it launched in 2022. And thank you to the team for all the hard work to stand up the program and get it moving and keeping it moving forward. There's a lot of movement in this arena, and it takes a lot of time and effort to go through the analysis and bring conversation back to you all. Then the last item one of the last items I have is cost growth target program. Just to let you know that the Cost Growth Target Advisory Committee is meeting next week from 9 to noon on Wednesday, January 18th. The agenda includes an overview of bills for the upcoming legislative session that may affect healthcare costs in Oregon, and a presentation from the Prescription Drug Affordability Board on legislative recommendations and strategies to address prescription drug costs. So that is upcoming, and I just wanted to make sure that you all were aware of that, as I know that's a key component of healthcare overall too, and the cost drivers that are a part of that. With that, Mr. Chair, I think I've concluded my update for today. Happy to be here. Thank you for having me and being so gracious. And if there's anything that I or anyone else at Oregon Health Authority can do, please let us know.
Thank you so much, Chris, for that agency update. Any other comments or questions from the board? I'd also like to just thank the board members for their thoughtful questions. We do have another HCMO, more robust HCMO presentation later today during our meeting. So really looking forward to hearing more about that program. And thank you for your suggestion, John. We will definitely take that as we move forward with some of the planning meetings. All right, so moving forward to our next agenda item, we have Vivian and Laurel, who are joining us today to share updates on the unwinding of continuous eligibility requirements in Oregon, as well as the Bridge program. Vivian and Laurel will speak to the implications of the 2023 omnibus bill signed by President Biden and how that will impact their work. Let's go ahead and have them take it away.
Hi, everyone. This is Vivian Levy. I'm so sorry I'm not able to start my video. It looks like there's some kind of error there, but I will be presenting to you along with my colleague Laurel today, and just trying to give some information about what the implications are of what is happening and what we are facing in the future. So if we can go ahead and pull up the presentation. Thank you so much. All right, I'm going to start my video. There we go. If you go to the first slide, please. So as all of you are very well aware, during the public health emergency, people have had continuous Medicaid coverage. Once they are found eligible for Medicaid or CHIP, they continue to remain eligible. Even though we have been continuing to go through our redetermination process, we have not been closing people as a result of changes in circumstance that they experience after their initial eligibility determination. And as a result of the unwinding, we will be in the position of needing to redetermine everybody who's receiving Oregon Health Plan within a finite period of time to find out whether they are eligible after the continuous coverage requirement has ended. Next slide, please. So the omnibus bill was signed at the very end of 2022. And that bill did two primary things that really impact this conversation. The first one is that it delinked the continuous coverage requirement for Medicaid from the public health emergency end date. And it gave us a timeline, which I will speak about in a minute, for when we needed to start the redetermination process and actually start closing people. The other thing that it did is that it gave us an end date for the SNAP, the Supplemental Nutrition Emergency Allotments. These things were both originally tied to the federal declaration, and they were untied by this omnibus bill. Next slide, please. So what does this new law do? So it requires us to start to end our continuous coverage requirement at the end of March of this year, and to start the redetermination process as part of the unwinding, which we no longer call the PHE unwinding because the PHE is not ending yet. So it directs us to start that redetermination process. And it gives us a total of 14 months over which to redetermine people and complete any actions related to that redetermination. It also provides some new and increased reporting requirements that states have to comply with, report out to CMS, and CMS will make public nationally. It does have a continuous coverage requirement for children, people up to 19 for 1 year. Oregon has actually had that policy in place for many, many years, so we are ahead of the game, and Oregon will also be expanding continuous eligibility for children and adults as a result of our 1115 Medicaid waiver in the future. This new law also makes the postpartum continuous coverage option permanent. Oregon has already implemented that option for 12 months postpartum coverage, and that will continue. And it sunsets the SNAP emergency allotment with a February 2023 issuance. And what that means is that February will be the last month in which people will receive their SNAP emergency allotment. And for many people, this could be, for many families, this could be a reduction of hundreds of dollars of SNAP allotment each month that they'll be receiving. So that we expect to have a huge impact on Oregonians, and an impact, of course, on our shared members and our shared customers. Next slide, please. So what does this mean? It means that we are going to initiate this process that we have been planning for such a long time, preparing for, but did not know when it was actually going to start. We are continuing to learn, we're continuing to get more information, interact with our community work group, who is giving us direct feedback and sharing their expertise about how we can best support people through this process. So this is not a line in the sand where we stop discovering and just start doing. It's sort of part of this continuum that we have. We are learning as much as we can, implementing the most effective changes that we can throughout this whole process, because we have never done this before. We don't know the perfect way to do it, and we want to make sure that we're doing the best job that we can continuously throughout the 14 months that we will be going through this unwinding. And that includes making sure that our communications and our outreach plans, both internally and externally, are as strong as they can be, so that people know what is going on. That is one of the most important things to us in this whole effort, is to ensure that people have clear and consistent information, so that they are not confused or unduly stressed about what's going to happen to them. Next slide, please. So this is the redetermination timeline that we are looking at now that we have information about when things are actually going to happen. March 1st is when the extra food benefits under SNAP will end, and those emergency allotments will no longer be going out. And then April 1st is when Oregon Health Plan will begin its first redetermination process under the unwinding, which means that we will provide people with that 90-day time frame to respond to renewals or send us verification. And then if somebody is no longer eligible, we will give them a 60-day period of time before their closure is actually effective, so that they have time to secure other types of coverage if possible. Next slide, please. So I know I have showed you all this before, so I'll just go over it very briefly. It continues to kind of center us and be what we come back to time and time again, to remember what our most important priorities are in this process, which is to ensure that people who continue to be eligible receive services without interruption in the least burdensome manner possible to them. The second goal is that for those who are no longer eligible as a result of these processes, we want to give them, again, clear, helpful communication that lets them know what their other options are and how to get to those other options and supports them in that process. And then really making sure that this wonderful, amazing network that we have in Oregon of community assisters, that they have the tools and the information that they need to be able to help our members and to help us through this process. Next slide, please. So I'm certainly not going to read this all to you. It's really just meant to show you kind of the continuum that we're on right now. We are in this preparation phase right now. We've been given a little bit of extra time beyond the 60 days that we were promised. There's 81 days till April 1st, but who's counting? So we are really still in that phase of encouraging people to update their contact information, working hard on communication and outreach plans so that we can do what we intend to do in the 60-day period, let people know what to expect, give them the information that they need. And then starting in April will be the first of those 14 months. The first of the actual renewals that we send out. And so April is when people will begin to receive notices in the mail or in their applicant portal account, letting them know that it is time to renew. Next slide, please. I'm going to turn this slide over to my, my colleague Laurel, who is working hard on the basic health program and bridge program, and then we will take questions.
Thanks, Vivian. Hi, everyone. For the record, my name is Laurel Swerdlow. I use she and her pronouns. I am the project lead for the bridge program. And when we last checked in with you all, the Legislative Bridge Healthcare Program Task Force was about to vote on its final recommendations. And I'm excited to share that the task force unanimously approved its recommendations back in December. As a reminder, the task force is recommending that the agency pursue a phased basic health program that will eventually cover folks 138 to 200% of the federal poverty level, offering OHP benefits at no cost to the enrollee. As we've shared with you all before, the first phase of the bridge program will be temporarily expanding OHP to 200% FPL during our redeterminations process. We submitted our application for this policy back in the fall, and CMS has indicated that they're ready to work with us to get this provision up and running in time for the end of continuous coverage. Now that we have a date for when continuous coverage ends, our goal is to have Medicaid temporarily expanded up to 200% FPL starting April 1st. Since the task force finalized its recommendations, we've been working to fill out what's called the Basic Health Program Blueprint. This is essentially the BHP application that is authorized under Section 1331 of the Affordable Care Act. Our plan is to have that ready for tribal engagement and public comment by May, so that we can have a final BHP blueprint ready for you all to approve and to submit to CMS in July. If all goes as planned, the BHP will be partially launched when redeterminations end in July of 2024. This will be when folks who were in that temporary Medicaid expansion category transition over to basic health program coverage. Then starting in January of 2025, the BHP will open up to folks 138 to 200% FPL who are currently uninsured, as well as those currently covered by the marketplace. So we're excited to finally put some dates to this timeline that we've been sharing with you all over the past 6 months. And I look forward to continuing to check in with you all as this work progresses. With that, I think we're ready to take some questions.
Thank you, Vivian and Laurel, for your presentation. Questions from the board? Feels like it's becoming real now.
It does indeed.
I guess what is your suggestion as you create this blueprint of this plan that is going to be coming to the board for approval? curious to hear about like how the board can be engaged in reviewing this blueprint between now and its approval date later this year.
Thank you. Yeah. So we plan to check in with you all again, likely in April, the month prior to us bringing this application forward for tribal engagement and public comment. I think that will be a really good space where we can dig in a bit more into this blueprint. I will say we've been talking about the content of this blueprint over the past six to 9 months with the task force. So I think we have been slowly integrating a lot of the feedback that we've gotten from you all over the past 6 to 9 months. But we would love the opportunity in April for us to dig in again to make sure we captured it all.
Great, thank you. John?
Yeah, very, very interesting work. So I'm trying to figure out, help me from a delivery system point of view. In the first phase where CMS okays folks staying in OHP, then they stay in the CCO system, correct? But then in the bridge plan, that moves them out of OHP, correct?
It moves them out of OHP, but they stay in their CCOs.
Okay, that's what I wanted to get at. So they stay in the CCOs, but those funds are now coming from the exchange.
They're coming from the Basic Health Program Trust Fund from the feds. The way that the Section 1331 is structured is it allows for states to create a trust fund wherein the dollars that would have gone to individuals to purchase coverage on the exchange are instead funneled to the state, and the state is allowed to create coverage and create a program for folks 138 to 200% FPL.
And so they would stay in CCOs, or would they have the option of going to the exchange, or they'll stay in their CCOs? And so the CCOs will continue to receive funding for that subset of patients.
That's right. The task force did recommend that the agency consider a final phase that allows for folks in this income category to choose between coverage on the Basic Health Program and coverage on the exchange. But in the short term, once we do fully launch this Basic Health Program, everyone 138 to 200% FPL, for the most part, everyone, there are some exceptions, would be getting their coverage through this Basic Health Program through CCOs.
So the delivery system changes are minimal, it appears.
That's the goal.
Yeah, okay.
Thanks, John. Brenda?
Thanks for the presentation and the hard work. And John, I appreciated your question too. I think it's really important to bring it to the, where it really matters, right? In terms of the delivery system itself. And so I guess my question is around the task force and the kinds of hurdles you're anticipating in either the planning phase, the continuous planning phases, or in the implementation phase itself. Are there one or two that you're paying close attention that we should also know about?
Thanks. I appreciate that question. I think in many ways we did a lot of the hard work in the task force over the past 9 months in creating this recommendation. There are a few hurdles that we're still anticipating, specifically with regards to our ability to secure a form of mitigating any impact to the market. When we do eventually get to that final iteration of the program, when folks who are currently covered by the marketplace are transitioned over to the Basic Health Program, our goal is to be mitigating any impacts that the market might experience from that transition. And so we're exploring opportunities through our reinsurance waiver to figure out a way that we might be able to mitigate impact both to the market, but also specifically to consumers to make sure that they don't experience any premium changes, or that any premium changes that they do experience are as minimal as possible as a result of implementing this program. So I would say right now, that's probably the main hurdle that we're really trying to make sure that we're laser focused on.
I think in previous presentations, we've heard about some of the workforce challenges in terms of being able to redetermine all these people in a finite amount of time. I was wondering if you could speak more about, anything that, has that been, how is that going? Has there been any progress in terms of those hiring of those folks and standing up with those systems?
So what I can say is ODHS has continued to hire eligibility staff with whatever positions they have and to fill those as quickly as possible. There is a pretty strong training effort that started just yesterday around workforce readiness. And we have put in a number of kind of increased automation features into our eligibility system to try to mitigate some of the impact so that, the system is doing as many things that doing the things that the computer is good at so that staff can do the things that staff need to do and that staff are good at. I certainly would not tell you that we are in a place where workforce is of no concern. I think that there is still, we still have a workforce that is understaffed and that has kind of a big hill in front of them in terms of all of the things that need to be learned and prepared for before April 1st. So we are working in close collaboration with ODHS to do whatever we can to make sure that they're prepared as possible. And that's another part of the incorporating learnings as we go through the first few months of these redeterminations. We're going to find any ways that we can to improve our efficiency and help out there.
Sandy.
Thank you. So with the one eligibility systems, I know sometimes there's some systems that aren't working correctly. So have you got all those kinks worked out on that? I mean, we're going from OHA to the marketplace exchange, and we know the platform's a federal government platform. Are you not gonna, I'm just thinking about how it's worked in the past, and then it went from OHA to DHS for the SNAP program and eligibility. Are those people that hit the, that may be that FPL level, are they going to fall off and then not to get redetermined, or how does that, I guess I'm kind of concerned about that transition when you've got 1.4 million people. I know when there was some redeterminations back, back in the day when the FPL level changed, there was numerous people that got lost in the system. So, and, long calls, trying to get people redetermined. I guess that transition do we know that it's not going to affect a lot of people, or are we going to be overwhelmed and hit all at once with that? So, because there were so many people that got redetermined all at once versus, it used to be by the date that you actually applied for the Oregon Health Authority. And so I guess that's pretty concerning to me, actually having had done it a long time ago. So.
Absolutely. Thank you so much for that question. I too was around for the implementation of the Affordable Care Act and lived through and dealt with many of those really difficult situations where we were unable to help people in a timely manner in the way that we needed to. And we have a saying, which is only new mistakes. Meaning we try our very best to learn from what has happened in the past and to apply those lessons as much as we can. So some things that I think are really different about this time around. We have an eligibility system that is flawed and that has issues, but that is able to make accurate eligibility determinations in the majority of circumstances, which is something that we did not have back then. We have, this system has been live and out there since 2020, went live in June of 2020. And so we have found and fixed many, many things since then. There will be more things to find and fix. That is the reality of any big complicated IT system. And there are some things that we're aware of that are already in the process of being fixed. And there are also things that we will discover. What I can tell you is that the last year has really been focused on building this new functionality to support this redetermination period and the time that comes after it, and to test the heck out of it to make sure that it works the way that we expect it to. And one of the things that we've done is we're taking everybody that exists in the system and we're loading them into a test system, and we're running all of these processes as if we were running them in real life, so that we can learn lessons before we're doing these things to real people. We didn't have the capacity to do any of that back during ACA implementation. So will there be no problems? Absolutely not. I would never promise you that. But our whole focus, our whole goal is on the member, supporting them and doing everything that we can to put them in the center of this process. And I do think that we've learned many lessons and we will do better this time.
So I just have one follow-up question as far as hospitalization, with COVID and so forth, and people falling off and then being hospitalized and having no medical coverage. Is that still going to be offered within the hospital system or not?
We absolutely we have an existing program called Hospital Presumptive Eligibility.
Right. Yeah,
yes, and we will absolutely be continuing to support that program and expanding it where possible to make sure that whenever people present and need immediate care and don't have coverage, that they're able to get that coverage. Absolutely.
Thank you.
Of course.
Thank you for the great questions. Any other questions from the board? Well, thank you again, Vivian and Laurel, for the great presentation. And thank you for all the work that you're doing to support this process. Really appreciate the cross-agency collaboration. So thank you. Okay, next up, we have Neelam Gupta, OHA Director of Clinical Support Integration and Workforce Unit. Joining our very own board member and liaison to the Healthcare Workforce Committee, Brenda. They're going to present the Healthcare Provider Incentive Program's proposed funding allocation request. So I am going to hand it over to them.
Thanks. I'll just do a few little introductory comments in appreciation of the Healthcare Workforce Committee and the OHA staff that do a lot of heavy lifting at a time in our state's history where this issue couldn't be more front and center for many of us. So I really want to just introduce Neelam, and at the end of her presentation, we'll have a vote for this board. So Neelam.
Great. Thank you so much, Brenda. And thank you for having us here today. I just want to mention I'm joined by colleagues who work with me to implement these incentives. Mark Overbeck, who I know you're all very familiar with, as well as two newer team members, Leah Festa and Jill Boyd. If you could pull up the PowerPoint presentation. Thank you so much. Next slide, please. We're just going to be going through a background as well as a reminder about the equity framework that we apply in making our allocation recommendations, and then review our proposed reallocation request, and then allow time for any discussion and questions and answers from all of you before taking the vote. Next slide, please. Some background on the Healthcare Provider Incentive Program. The program exists within the Healthcare Provider Incentive Fund, both of which were created under House Bill 3261 in 2017. The intent was to take several separate funding streams for provider incentives and bring them under a single fund and program. This fund and the programs under it are administered by OHA in collaboration with the Oregon Office of Rural Health at OHSU. And these funds and programs are under the policy direction of the Oregon Health Policy Board. The Oregon Health Policy Board relies on recommendations from the Healthcare Workforce Committee and the Primary Care Office, which staffs the committee, in making allocation each biennium and requesting adjustments if needed. And that's why we're here before you today. Next slide, please. So just to provide you an overview of the allocation change that we are requesting, we intend to, it's broken into 4 different areas. We had come before you in August of 2022 to request an allocation adjustment, really to increase our loan repayment incentive, given that we had just experienced incredible demand for this proven incentive. And that demand continues today. So the first adjustment is reducing the rural medical malpractice insurance subsidy by $900,000, given projected underspending, and then adding $500,000 from the cash balance in the fund to the program. The second adjustment, as I mentioned, is to add an additional $400,000 to loan repayment, given the high demand and need for debt relief that we continue to see. And then the third adjustment we're asking for is to add $700,000 to our administrative costs for an increase in our Office for Rural Health contract. We have a very slight increase in our OHA personnel. And then given the many studies that our office has been overseeing, we contracted with Oregon State University for the healthcare workforce needs assessment. And so that also is an additional cost as well. And then lastly, this is a new request, is to add $300,000 to provide matching funds for the state loan repayment program that is funded through a grant from the federal government. And it is administered by the Office of Rural Health at OHSU. Next slide, please. And then just as a reminder, we, the Healthcare Workforce Committee in November of 2021 had come before the Oregon Health Policy Board for approval of our equity framework. This framework really came about through a question that the Oregon Health Policy Board asked us. Do we have a framework or lens that we use in determining our policy allocation or funding allocations? And that started a process through which we had done close to 30 listening engagements really to inform our thinking and our ways in which we allocate funds and guide our discussions. This has the list of questions that we developed based on the listening we had done that really strive to answer the question, how do Oregon's healthcare workforce development efforts advance opportunities for communities experiencing health inequities? And you'll see in the subsequent slides, we apply at least one of these questions to each of the funding allocation requests. Next slide, please. So our loan repayment increase, again, you know, this will sound familiar to what we had presented back in August. Loan repayment continues to be a proven incentive that garners tremendous interest. We continue to see more applicants than awards that are possible to be made from available funding. We make competitive awards based on a scoring rubric promoting health equity. The guiding question that we use in making this recommendation is, how should we modify or enhance strategies to ensure recipient and community needs are met? How have we intentionally involved community representatives affected by the resource allocation? And you know, the rationale again remains the same as when we came before you in August. The primary care office and the healthcare workforce committee continue to hear from providers that there is a tremendous need for loan repayment to support the retention of providers and the recruitment of providers to areas and practice environments that cannot compete with others that pay higher wages. Next slide, please. And then the justification for the increase in our administrative costs. They have increased given the growth in the number of incentives contracts. We have over 240 incentives contracts right now amongst all the different incentives. We also have invested quite heavily in increased marketing and new ways to reach providers from communities experiencing inequities. And as I mentioned earlier, this you know, one-time need to contract for our healthcare workforce needs assessment, which you will be hearing about later in the agenda. The guiding question leading to this decision is, how should we modify or enhance strategies to ensure recipient community needs are being met? And you know, the rationale is that the primary care office and its contractors require additional funds to effectively administer, market, and evolve incentives and conduct studies that address workforce shortages and a lack of diversity. Next slide, please. And then, you know, again, this is a new request. This is a one-time request. The state loan repayment program is administered by the Oregon Office of Rural Health at OHSU. This is a program funded by the federal government, the Health Resources and Services Administration. This is grant money that is provided to states and territories. Each state and territory can design the program to address the most pressing healthcare needs in primary care, behavioral health, and dental health. In particular, OHSU, which administers this program, has encountered difficulties in securing matching funds from practice sites. There is a requirement that there are matching funds to secure, to draw down this funding. And these challenges have been encountered due to the COVID-19 pandemic. And without these matching funds, the Office of Rural Health would have to return $300,000 to the federal government for this proven incentive. And so these funds we're estimating would allow 10 providers to be placed and retained in areas of high need. The guiding question leading to this decision is, how should we modify or enhance strategies to ensure recipient and community needs are met? How do we align and leverage public and private resources to maximize impact? And the rationale is very similar to our previous loan repayment ask. Again, we continue to hear from providers that the need for loan repayment is just very high, and the need for debt relief continues. Next slide, please. So this is then the point where we would love to hear your questions and then ask for your approval.
Thank you so much for that presentation, Neelam. Questions? Looks like Bill, go ahead.
Neelam, thanks very much for this good presentation and the description of the rationale. I wanted to ask, probe a little bit more about the rationale for the administrative cost increase. I understood what you said, but I see that it's a very large number. And just last summer, 1.3 million was considered sufficient. And that was the request that was approved. And now it's an increase of more than 50%. The rationale that's given on the slide is simply saying they require additional funds. And it would be helpful to know what's the impact of what I guess the PCO and its contractors consider insufficient funds. Are they behind on processing things, or are they what's the actual impact of this supposed underfunding? Or put another way, what could be accomplished with the additional funding that's not being accomplished now? Because ideally, we'd like to make sure we're using our administrative funds as efficiently as possible to ensure that the money is going directly for the intent of the program.
Sure. No, thank you for the question. We did hear, we did do a survey of providers this past summer, where we did hear that they were encountering more barriers, in particular loan repayment, because that is one of the largest incentives. They were encountering more barriers to accessing funds in a timely manner. So that, and we also added on a communications person so that the communications piece could be streamlined. Mark, did you want to add anything on as well?
I don't think so, really, Neelam. I think you said it well, and really, Bill, to your question, we have heard from the community that the funds are not known sufficiently by communities, particularly those experiencing inequities. So the addition of the communications staff member to be able to have a more robust program. This is a multi-million-dollar program, and historically, there's been just one staff person full-time assigned to the program. So made a calculated decision based on the equity framework that we really need to we need to make more robust the staff that's administering this growing program to serve a growing problem.
So you're saying that it's primarily for outreach to providers and communities that are traditionally underserved because they're feeling not addressing the goals of the equity framework.
Both
How
with-
much of the 700,000 is for that additional communications and outreach?
Neil, you may be able to speak to person.
Yeah, I'm not sure, but we could get back to you with that information. I also wanted to mention too that, you know, our staff also has really leaned into convening provider work groups of providers of color as well, and other communities experiencing equities to do things like revise our loan repayment application to meet accessibility requirements. And so, you know, we also, you know, modified our scoring criteria as well, you know, based on feedback. So there have been, you know, multiple other efforts as well.
Thanks.
John and then Kristen.
Yeah, I'm for the funding changes being suggested. As I read, you know, I'm growing in both appreciation and concern about how difficult and how much stress is on the horizon in terms of the workforce issues. You know, our focus has been probably more on getting people up and started and recruited and bringing them into the system, which is appropriate. But some of the materials, you know, really focused on resilience and who is hanging in there, who's not, and why not, and you know, what's going on with the system. And I think that's really important. And you know, sorry, but to connect the dots, when you have a primary care option owned by one of the nation's largest companies, that's a membership model that requires a $200 fee per year per patient. Do the math. The typical family practice has 2,000 patients. That's $400,000 per primary care practice. Do you think some primary care doctors in Oregon might go, maybe the grass is greener over there? You know, we need to wake up to what's going on here. You know, I think when you have a vulnerable workforce, folks see that as an asset that they can, you know, engage and have an advantage in the marketplace as a result. So, you know, my guess is what we're talking about here is not going to be near enough to figure out really what's going on in this case. Keep at it, you all. I'm for this. I would be interested in knowing where the $700,000 is going specifically. I think Bill's issue is important, but we need to do as much as we can here. Thanks.
Thank you, John. Kristen.
Yeah, thank you for your comments, John. I also can't help but think about the impact of the cherry picking of patients that comes with that and how that impacts our system and resiliency of workers in different places. But to our topic at hand today and to our presenters, I too will be supporting this motion, but I do have one comment and one question. One, just hearing about the loan repayments and demand for those, and I think these are important programs, but I also can't help but think about when we all the barriers that prevent many people from even getting to a point of being able to apply for a loan repayment, including like not even like I didn't go to med school because, and so as we maybe take, I know that the extra money to expand administrative capacity here, of course, responding to an urgent need, but I can't help but just to go on the record in this opportunity to say that like eventually we need to develop a part of this program, or I would like to see a workforce development program supported by the state that not only does loan repayment, but also helps with some of those earlier barriers. So I know that like our ed fund helps housekeepers go to school while they're working to become a licensed medical professional. And I really think how do we raise up within our community, within our state earlier? So I'd love to support an effort like that as well. And then more specific thinking about this, the matching funds for the loan repayment program. I'm happy to see that we are not, that we are finding ways to not return a large chunk of money to the federal government. I support that. And I am sympathetic that there are some definite financial impacts over the past few years on many of our practices. I have to say that like I hope that a kind of a double check is being taken on the practice sites, because I've seen profit margins of many rural hospitals, some are hurting and some are not. And so I would just hope that it's been thoughtfully reviewed to ensure that this is truly a need. And then I guess I have some questions about kind of the long term, like if we step in now and devote that money to this, will there be the expectation that that continues to happen? And how do we, when appropriate, wean off of that? Thank you.
Yeah, no, thank you so much for those questions and for those insights. I couldn't agree more that, some of these incentives are very downstream and a lot of the needs are, more upstream, and those require tremendous investments. And we, some of which probably started many years ago, and we just need to do more of that. We look forward to coming back to you next month to talk more about the incentives, the provider incentives evaluation, where we're going to be digging a little bit more into that. And then, we definitely intend to make sure that this funding goes to the highest need practice sites. The Office of Rural Health has its unmet healthcare need process that it's going to apply, and we intend to partner with them to, make sure that this does go to really high need sites. And then the last part of your question, or comments, I'm missing. Mark, and maybe you can help me with that.
Sure. Kirsten, you asked that we make sure, if we can, that we're not going to be coming back again to try to maintain not returning federal money, and we can say definitely yes. Historically, the federal SLRP program, or the state loan repayment program, has required a match. The Biden administration has now eliminated the need for a state match. So this was the one and the last time where we'll be providing, based on your support, if you approve this, the matching funds directly from the Healthcare Provider Incentive Fund, which will not be required in the future. And it's the first time that we've asked for that match.
Great. Melina, welcome. You have a question or comment?
Yes, thank you and good morning. Thank you for your presentation. I am also in favor of this, and also do have questions on that 700,000, and I would love to see a breakdown on where that's allocated and how many people that's supporting. Another question I have that I would like to see is, you mentioned that you did not have enough funds for the provider incentive program. I'm wondering how many applications were turned away is one question. And then I'd love to see a breakdown of what specialties applied and were accepted.
I don't have that data in front of me, but we can definitely get it to you. We intend to present it next month when we come back with a provider incentives evaluation. But I want to say about half of the loan repayment applications this past year were turned away. And we could definitely get you more detailed information, and we'll come back next month with that.
All right, thank you. That's a high number. Thank you.
Sandy.
Yeah, you had stated that some of this would be utilized through OHSU for a, I guess, a review or analysis of what was going on, regarding rural health providers and so forth, the locations. Has that been conducted, or this will be conducted? I mean, I guess I'm a little, I don't see any data analysis in regards to the program. So I guess I got to go look for that. So
we will be coming back next month. The program is required every 2 years to do an evaluation of effectiveness. And we have expanded that to include other provider incentives this year. So we are coming back next month to present on that.
Okay, thank you so much.
Great. Any other questions or comments? Just a couple of thoughts from me. I tend to believe that you have to have a strong administrative backbone to be able to do amazing programmatic work. So quick back of the napkin calculation looks like this is less than 12% admin funds, which seems like maybe we're actually getting to the admin funds that program actually really needs. Maybe we're getting closer to that. But yeah, I would love to sort of get a follow-up about the breakdown of how the 700,000 will be used. And then Kristen, I loved your comments because they were really in alignment with some of the things that I was doing is, obviously this is a successful program that's getting a lot of interest and more than we can actually serve. And I'd love to see and I know we're going to have a more robust presentation about healthcare workforce, but how can we replicate this sort of program in other areas, right? Like whether it is to try to incentivize parts of the healthcare workforce where we're getting CNAs to become CMAs to become, kind of moving up the professional ladder. So really interested in potentially exploring that in the future. And yeah, I believe, Brenda, would you like to make the motion here?
Sure, I'm happy to, and I think at the pleasure of the board, whether or not you'd like that additional detail to feel confident in this action or by which we can provide that, or if you're ready to take action today. So we could go either way. So having said that, I'd like to move approval to the Healthcare Workforce Committee's recommendations for the reallocation of resources for the Healthcare Provider Incentive Program.
Thank you, Brenda. Is there a second?
Second.
Thank you, John. All those in favor, please say aye.
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 Anybody oppose? Anyone? Bill opposes. Thank you, Bill. And any abstentions? All right. Well, that is approved. Thank you so much. And we look forward to hearing more about the breakdown of the administrative funds. So we're going to make a quick agenda change. We're going to go into break now, and then in 10 minutes, we will come back with public testimony. So we will return at 10:20. Thanks. All right, welcome back from the break. If I could have my fellow board members, if they can, either do a thumbs up or turn their video on so we know that they're back. Right. All right, we are going to return to public testimony. So the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with the thoughtful attention, respect, and honor that you deserve. Public comments are meant to provide everyone an opportunity to share their perspective and be heard. However, public comments are not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and if that doesn't feel like enough time, we encourage everyone to provide written testimony, which we commit to reading. To help keep us on time, we'll start a slide with a 2-minute timer for each presenter, and we kindly ask that the presenter conclude their presentation when the timer is complete. Please note that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next step with each public speaker. I believe Karen Christensen is signed up to speak today. Karen, when you are ready, please begin.
Thank you, Mr. Chair. My name is Karen Christensen and I live in Corvallis. I'm a member of Healthcare for All Oregon, as well as Mid-Valley Healthcare Associates. I'd like to thank you for this opportunity to speak to you today. I've been listening to your discussions today and for the past year, and I'm struck time and time again by the complexity of our system and the effort that it takes to figure out who is entitled to health care and on what basis. The system should not be this complex. During this legislative session, a very important bill is being introduced that represents the next steps forward as recommended by the task force that was formed by Senate Bill 770 on universal single payer healthcare. I know that you're quite aware of this because Member John Santa has been intimately involved in that process. For over 2 years, this board worked diligently to determine how we can improve our healthcare system in Oregon, and their recommendations were submitted to the legislature at the end of September. Their work was to create a blueprint for a state plan and the establishment of a board for universal care. The governance board plan is being introduced in both the House and the Senate. The board will have the task of completing a full range of single payer implementation for review and consideration by the 2025 Assembly. I'm asking that the Oregon Health Policy Board support the legislation to create the governance board for a single payer plan. We can, in fact, provide better care for more people for less money. And this is the first step to making that concrete reality, which could enroll people by 2026. We need to move forward on the 2 years of work of the task force, and I ask for your support in that effort. Thank you very much for this opportunity to speak.
Thank you so much, Karen, for your comments. We'll follow up accordingly. Okay, next on our agenda, we have the Health Policy and Public Health team from Oregon State University joining us today to present Oregon's Healthcare Workforce Needs Assessment. As you probably remember, we hosted an educational webinar on the needs assessment last month in preparation for today's presentation, and the statutory requirement for OHPB to vote on the approval of the needs assessment before it is submitted to the legislature. So thank you for joining us from the OSU team. Please begin when you're ready.
Thank you very much. Thank you very much for having us today to present our report of the Oregon Healthcare Workforce Needs Assessment 2023. Our team at Oregon State University collaborate and work closely with Mark Needham and Craig, the project advisory group, the workforce committee, and all content experts to develop this report. We greatly appreciate all their support. We presented our report to the Healthcare Workforce Committee and Health Quality Board, and we received very helpful comments and feedback. We will highlight a few recommendations per their suggestions in this presentation. Next slide, please. Oregon has long been working to transform its healthcare system to ensure that all people in Oregon can reach their full health potential and well-being. Oregon's goal of eliminating health inequities requires the preparation, recruitment, and retention of a diverse workforce. In 2017, the Oregon legislature passed House Bill 3261. This bill directed the Oregon Health Policy Board and OHA to produce a biennial assessment of the healthcare workforce needed to meet the needs of patients and communities in Oregon. The 2023 Healthcare Workforce Needs Assessment will be the fourth report published by OHA. The purpose of this report is to inform investments going forward. We use OHA's annotated outline and summarize existing data to develop this report. Please note that some data in this current report is preliminary and subject to change. Now I will pass to Colin Peterson to report the reinvestment section. Colin, please.
Next slide. So Oregon has made a concerted effort to expand existing investments and make new investments in programs that help expand the healthcare workforce since the last Healthcare Workforce Needs Assessment. Existing programs like the Healthcare Provider Incentive Program, which includes loan repayment, loan forgiveness, malpractice subsidies, and scholarship incentives, as well as other incentives that are a part of the Healthcare Provider Incentive Fund, have received additional funding, as you can see in the table. I also included some highlights on the next slide for the Rural Medical Tax Credit and Healthy Oregon Workforce Training Opportunity Grant Program, the How-To Grant Program, which are also a part of the Healthcare Incentive Fund. Over the past 2 years, there have been several changes to financial incentives within the Healthcare Provider Incentive Fund. Major investments have been made in the behavioral health workforce via the Behavioral Health Workforce Initiative, which will be talked about later in the behavioral health section. Other changes include providing flexibility for awardees to practice via telehealth, beginning the collection of REAL-D data for race and ethnicity categories, and focusing on ways to better serve communities experiencing inequities and supporting providers of color. Next slide. So investments have been made outside the Healthcare Provider Incentive Fund as well. The OHSU 30-30-30 plan and Future Ready Oregon hope to increase education and training capacities for healthcare workers, while also increasing the diversity of the future healthcare workforce. As far as our recommendations regarding investment, we include continuing to work with the public workforce system and allied educational partners to continue to invest in workforce training and continuing to fund financial incentives like those in the Healthcare Provider Incentive Program and Healthcare Provider Incentive Fund. These remain important tools to addressing workforce shortages. And I know earlier in the meeting, you guys addressed some of this. It is also important to evaluate and monitor the effectiveness of current incentive programs. So measures like cost per placement year across different healthcare professionals and retention effectiveness can help evaluate the effectiveness of incentive programs in achieving their goals of addressing workforce needs and inequities in underserved communities. Finally, investments must address other factors that affect recruitment and retention outside of workforce-related financial needs in rural areas. Things like housing costs and supply, economic opportunities for partners or spouses, and K-12 education needs have been mentioned as recruitment barriers, and additional data should be collected in this area in the future. Now I'll pass it back to Dr. Lee.
Thank you. Next slide, please. Healthcare workforce burnout is a long-standing issue which has been exacerbated by the COVID-19 pandemic. A national survey found that over 60% of physicians reported burnout in 2021, compared with only 38% in 2020. As of November 2021, over 70% of Oregon primary care providers reported that mental stress in their practices at all-time high, compared to around 60% at national level. The study by Oregon Center for Nursing found that 83% of nurses reported stress. Health worker burnout can have many negative consequences. A national study found that more than 30% of nurses who left their job reported burnout as a reason. Study estimated the national cost for burnout related turnover at $17 billion for physicians and $14 billion for nurses. Next slide, please. There are national and state level investments and programs to improve workforce resilience. Just a few examples here. In 2021, the U.S. Department of Health and Human Services allocated $103 million to be spent over a 3-year period to reduce burnout and to promote mental health among the health workforce. The passage of Dr. Lorna Breen Healthcare Provider Protection Act in 2022 established grants and requires activities to support the mental and behavioral health of health workers. In Oregon, the Oregon Center for Nursing launched the RN Wellbeing Project in 2021 to aid workplaces in developing interventions that are necessary to improve nurses' mental and emotional well-being. OCN is working on innovative solutions for employers to make systematic culture change to best support their nurses. OHA is also taking various steps to support behavioral health providers. More details are provided in our report. Next slide, please. A range of social, cultural, and organizational factors can contribute to healthcare workforce burnout. Therefore, systematic changes and collaborative actions are required to prevent burnout and improve well-being. In October 2022, the National Academy of Medicine published a national plan for health workforce well-being. It calls on multiple actors to cultivate health systems to support care provider and optimize their well-being. The 2022 U.S. Surgeon General's Advisory also called for collaboration from a variety of public and private stakeholders to tackle healthcare worker burnout. We highlighted some recommendations here. Next slide, please. According to the new report of Oregon Area of Unmet Healthcare Needs, rural and frontier areas have more unmet healthcare needs than urban areas in Oregon. For example, this figure here shows the primary care capacity by service area, with the shaded area being below the statewide primary care capacity ratio. In particular, the rural and frontier areas have a primary care capacity ratio less than 1, indicating that the number of healthcare providers is insufficient to meet the demand for primary care delivery. Next slide, please. The impact of COVID-19 on reduced healthcare visits and healthcare employment are greatest during the first months of the pandemic. Healthcare visits reduced significantly in April 2020. The reduction in healthcare visits and revenues led to layoffs. The pandemic also exacerbated healthcare workforce burnout to an alarming level. States took a variety of actions to address healthcare workforce needs. Healthcare facilities also greatly increased their use of temporary staffing agencies. The public health workforce was increased during the COVID-19 pandemic. In Oregon, between March 2020 and August 2021, FTE of local public health authority workforce increased about 70% for the COVID-19 response. Next slide, please. Current employment estimates show a rapid reversal of pandemic recession job losses. Within the healthcare sector, employment trends vary. Employment in ambulatory healthcare had bigger declines in spring 2020, but has had a stronger growth since then. On the other hand, there were slower but steadier declines in employment by hospitals and nursing and residential care facilities. As of August 2022, the number of people employed in these two sectors was still about 5% lower than pre-pandemic levels. Next slide, please. This figure shows the number of monthly online healthcare job postings. In May 2020, the number of monthly postings was about 1/3 lower than pre-pandemic levels, and the number of job postings began to rebound by July 2020. There were about 17,000 online healthcare job postings in September 2022, which is about 9% higher than 1 year ago. The fast job recovery, low unemployment, and high number of job openings have all increased difficulty for employers seeking to hire. Therefore, it is urgent to expand workforce training where shortages are most acute and invest in Oregon's education pipeline for healthcare professionals. Next slide, please. Now, Professor Jeff Luck will report telehealth section. Jeff, please.
Oh, thank you, Tao. So one of the telehealth was very important in helping to maintain access to healthcare providers during the pandemic, and it's now become common throughout the state. And in particular, utilization of telehealth by Oregon Health Plan members jumped dramatically from less than 1% of visits before the pandemic to roughly 1 in 10 visits in recent months. Those visits have been primarily for behavioral health, which accounts for more than half of telehealth visits, and primary care, which accounts for about 25% of telehealth visits. So there have been some longstanding concerns about potential racial ethnic disparities in access to telehealth services. Preliminary data so far from OHP, however, indicate that the rates of utilization of telehealth range from about 8% to about 11% of ambulatory care visits across all major racial ethnic groups in Oregon. So that's relatively even distribution. However, utilization of telehealth was much lower for rural and frontier members of OHP compared to urban members. The thing that made telehealth utilization jump, or one thing that allowed telehealth utilization to jump so dramatically during the early part of the pandemic was the relaxation of restrictions on, for example, what sites the patient could be at for telehealth. Oregon legislation made almost all of those restrictions permanent in the last couple of years. And when we spoke to the policy board last month, we were concerned that federal restrictions might be tightened again once the public health emergency lapses. Fortunately, in the Omnibus Spending Act that was passed in late December, CMS extended almost all of the telehealth flexibilities for 2 years. So that was really great news, actually. So with regard to policy recommendations in Oregon, we'll highlight a couple. First of all, now that REAL-D data is becoming more routinely available, this should be used to understand telehealth access by all potentially vulnerable groups and to ensure access for all those groups. And then second, to take more actions to increase telehealth access for rural and frontier residents of the state. Next slide, please. So with regard to the nursing workforce, we drew on excellent research that was done last fall by University of California, San Francisco in collaboration with the Oregon Center for Nursing. This was presented to the Workforce Committee as well. And so we'll just highlight a couple of their findings and a few of their recommendations. One important thing to understand about the nursing workforce in Oregon is that we increasingly depend on nurses who are trained in other states and then gain licensure in Oregon, whether they live here or work remotely. And then second, there's a long-standing geographic maldistribution of nurses in Oregon, which means that many or most of Oregon's rural and frontier areas have fewer nurses than urban areas do. And then the COVID-19 pandemic, as Tao described, dramatically increased burnout among nurses. It significantly limited their training opportunities. For example, student nurses were not able to get placements for clinical training, and it contributed to the shortages that we currently see, particularly in hospitals and long-term care facilities. So I really suggest reading the UCSF OCN report for a wide range of detailed recommendations. A couple of important ones are for the state to support employers to create healthier work environments to retain nurses once they've been trained. And then second, to strengthen the nurse training pipeline in Oregon at all stages. That's university and college education for LPNs and RNs, clinical placements, and apprenticeships for students to be able to earn an income while they're getting their credentials. Next slide, please. The long-term care workforce is extremely important in providing care for Oregonians who need assistance with daily activities and healthcare, both at their homes and in residential facilities like nursing homes, assisted living, memory care, etc. The demand for those kinds of services is expected to grow almost 30% in less than a decade as the Oregon population gets older. So this is one of the fastest growing, if not the fastest growing areas of need in the Oregon healthcare workforce. However, most workers in long-term care are female, are of low income. They're very often persons of color or immigrants. And they've faced several challenges for many years before the pandemic, specifically high turnover in their positions, low pay, and often very limited advancement opportunities career-wise. And the COVID-19 pandemic just made these problems even worse. And the result is what we've seen, first of all, high levels of stress and risk, especially early in the pandemic, and a continuing high number of unfilled positions in places like nursing facilities. Those staffing shortages in nursing facilities have actually led to backups even in hospitals and hospital emergency rooms. So it ripples throughout the system. The state, particularly OHP and Department of Human Services, have stepped in with short-term funding for facilities and direct staffing support for some facilities. That's been expensive, though, and difficult to maintain over the long term. So DHS also commissioned a study from an organization expert in the long-term care called PHI. And PHI also made several recommendations that are consistent with many other groups that have studied long-term care, in particular to improve, to strengthen the long-term care workforce, to increase compensation for these positions and provide more career growth pathways, to strengthen a variety of training programs, and similar to nursing, to provide higher quality work environments. So we'll look forward to your questions, but I'll hand it over to Dr. Irvin.
Good morning. Next slide, please. I'll be discussing today a few specific sectors. I'll be starting first with the traditional health worker sector. Traditional health workers are trusted individuals from their local communities who provide person and community-centered care by bridging communities and the health systems. As of October 2022, there were 4,400 certified traditional health workers in Oregon. These specialties include community health workers, peer wellness specialists, peer support specialists, personal health navigators, birth doulas, and as of 2022, tribal traditional health workers. OHA's Traditional Health Worker Program has recently launched a toolkit with information for health systems, providers, and traditional health workers. Oregon's Office of Rural Health and OHA coordinate a CDC grant-funded program to support the capacity of Oregon's rural public health agencies and critical access hospitals by growing the number of community health workers in the rural Oregon area. Recommendations include increased compensation, increased reach to all counties of the state. You'll see a varied amount of reach about different types of specialists throughout the state, but improving the reach across all these specialists across all the counties, and strategies to recruit, train, and employ providers of color and from other underrepresented communities. Next slide, please. Healthcare interpreters are bilingual individuals who help people in their communities with limited English proficiency or persons who communicate in sign language to interact effectively with healthcare providers.
Certified and qualified interpreters must have formal training and must pass national certification exams or language proficiency assessments. There are over 1,200 qualified and certified interpreters on the Oregon registry. A recent survey of the healthcare interpreters in Oregon revealed that there are 30 different languages spoken, with Spanish being the most frequent. And 11% of the healthcare interpreters who completed the survey had also completed the registry of interpreters for the deaf. In order to increase the number of certified healthcare interpreters, OHA has made some modifications, including removing all application fees and streamlining the application process. Recommendations for the healthcare interpreter workforce include policy options to improve compensation, such as paying 2-hour minimums and paying for no-shows. Improved programs and reach for training qualified and certified interpreters, especially in rural communities, and improved or enhanced technical assistance for providers in the healthcare system to better integrate healthcare interpreters. Next slide, please. Oral health providers. Oral health providers include dentists, dental therapists, dental hygienists, expanded practice dental hygienists, and dental assistants. In 2022, there were over 2,400 dentists and 260 expanded practice dental hygienists actively practicing in Oregon. OHA has received an oral health workforce grant from the Health Resources and Services Administration to expand teledentistry by funding community-based organizations and to integrate teledentistry services into their facilities. This grant will also partner with dental care organizations to maintain and place mobile dental vans for exams, x-rays, charting, and preventative services. And this grant will also partner with OHSU School of Dental Public Health to expand dental preceptor capacity and incentivize more dentists to become preceptors. Recommendations for the oral health workforce include identifying pathways for dental hygienists to grow into dental therapists, recruiting professionals from underrepresented groups, specifically Hispanic, Latino, Asian, Indian American, Alaska Native, and Black African American. Allow flexibility in state licensing for out-of-state or traveling providers, and to reach underserved groups through provider incentives, mobile dentistry, and teledentistry. Next slide, please. Public health workforce. Oregon's public health system is comprised of governmental state, local health authorities, and government-to-government relationships with federally recognized tribes, as well as partnerships with community-based organizations. There are approximately 1,000 current staff within the OHA Public Health Division. There are 33 local public health authorities, and OHA has funded more than 170 community-based organizations as part of the state's COVID-19 response. Challenges for the public health workforce include recruiting, retaining, and supporting a diverse and trained workforce, especially in rural areas and especially epidemiologists. Public health infrastructure has been underfunded starting before the pandemic, but OHA did start to invest in 2017 into the public health modernization funding, and they are continuing to invest. OHA Public Health Division has also applied for a CDC public health infrastructure grant with some of the funding focusing on workforce development. Recommendations for the public health workforce include increasing the workforce of homegrown professionals from our local communities, identifying online public health education, undergrad, graduate certificates, and recruiting and retaining current staff with salary adjustments, flexible work agreements, and allowing work experience or lived experience to be substituted for advanced degrees. That is the end of my presentation, and I'll pass it over to Dr. Lee. Thank you.
Thank you, Dr. Urban. Next slide, please. Primary care providers play a critical role during national health emergencies like COVID-19. Studies show that residents in communities with greater primary care access had better COVID-19 related outcomes. The COVID-19 pandemic has also highlighted the long-standing problems like underinvestment and workforce shortage in primary care. High-quality primary care is the foundation of high-functioning healthcare system. The 2021 report by National Academies of Science, Engineering, and Medicine made recommendations to achieve high-quality primary care and rebuild a strong foundation for the U.S. healthcare system. In Oregon, the patient-centered primary care home program is part of a comprehensive statewide strategy for health system transformation. There are over 600 primary care practices in Oregon that participate in the PCPCH program, and more than 3 million people living in Oregon receive care at PCPCH. We recommend Oregon to further improve PCPCH to emphasize health equity and support a high quality and patient-centered primary care system. Next slide, please. Behavioral health services are an important component of whole person care and are provided by a variety of practitioners. The behavioral health system has been faced with a severe workforce shortage. Study found that over 60% of Oregon health providers reported their organizations need more behavioral health providers. There are several national and state efforts to address behavioral health workforce shortages. In Oregon, the legislature allocated more than $1.35 billion in funding for 2021 to 2023 to transform Oregon's behavioral health system. The behavioral health workforce initiatives seek to provide incentive to increase recruitment and retention to providers in the behavioral health workforce, with a focus on equity and priority population. In 2022, the legislation provided $132 million general fund investment for OHA to distribute grants to behavioral health providers to increase compensation to staff and pay hiring and retention bonuses. In addition to increased compensation, it is important to reduce administrative and other workplace burdens to sustain a positive work environment and culture, and to increase recruitment and retention of providers with a focus on equity. Next slide, please. In addition to the recommendation for each specific provider type, we provide general recommendations to support overall workforce development. In particular, the Healthcare Workforce Committee and Health Policy Board gave us very helpful comments and feedback at our earlier presentation. We selected a few recommendations here. Additional recommendations are included in our report. For example, improve the diversity of healthcare providers, improve the supply and distribution of the healthcare workforce, enhance the resiliency and well-being of the healthcare workforce. Next slide, please. We also recommend expanding training. For example, we recommend investing in Oregon's education pipeline for healthcare professionals, including K-12 outreach, community college, bachelor's, online certificates, and education programs. Regarding care delivery models, we recommend expanding telehealth coupled with healthcare interpreters to ensure access for people needing culturally specific or linguistically appropriate services. We also find it is important to improve the data collection to promote evidence-informed strategies and diversify the healthcare workforce. For example, as we discussed before, a range of social economic factors and other neighborhood and community features may all contribute to workforce shortages and maldistribution. However, there is still currently lack of data for us to assess the complex impacts of all these factors on workforce recruitment and retention. Therefore, we recommend investing in collecting data that can improve our understanding of the complex impacts of these factors. Next slide, please. Workforce shortage and lack of diversity in many areas of healthcare are a national problem experienced in Oregon. In order to stabilize, expand, and diversify Oregon's healthcare workforce so that it can deliver culturally responsive, effective healthcare services to all, some professions need increased compensation to attract new individuals and increase retention. Many professions with unclear career pathways need better and focused pathways for increasing skills, pay, and impact. And all professions need more support around resilience and well-being. All the report's recommendations warrant action by government and non-governmental entities to ensure Oregon has the workforce it needs to deliver on the commitments of optimal health for everyone and the elimination of health inequities. Next slide, please. Again, we would like to thank Oregon Health Authority, the Project Advisory Group, the Workforce Committee, the Policy Board, and all the content experts for all their support to our work. Specifically, we would like to thank Leland, Mark, and Craig again for all their support to us. Thank you very much, and we appreciate all your feedback and questions.
Thank you so much to the OSU presentation team for the great presentation and the thoughtful and very thorough report and all your work in this area, as well as the OHA leadership. Questions and comments from the board? John.
Yeah, thanks for this report. It raises a number of issues. You know, I have a bias. I'm a primary care person. I look at slide 10, and the collapse of the primary care system was just stunning. Those people didn't quit. They were laid off. Some of them were laid off by the wealthiest healthcare organizations in the state. You know, folks like OHA, HealthShare, Care Oregon, many other many of the CCOs, they ran towards the fire and tried to do something. But a lot of healthcare organizations ran the other way. You know, when I look at that graph on slide 10, that just can't happen. That just can't happen again. That was awful. I remember that. I remember talking to primary care folks. Folks retired early. They laid off staff only because of the action of some organizations who stepped up, did this, you know, bottom out at 80%. It would have gotten a lot worse. I mean, the recommendation, I agree with the recommendation. There's underinvestment, but a lot of that is because there's not reliable investment in primary care because those organizations can walk away, and they do walk away. So for me, we need to be a lot more serious about this, at least for primary care. So, you know, thanks for exposing this. Just don't forget that graph on slide 10. Thanks.
Thank you, John, for your comment.
Thanks, John. Bill?
Thanks for this very helpful and informative report. Appreciate all the effort that went into it. Appreciate the presentations. Agree 110% with John's comments about the crisis in primary care. And I think things similar can be said about the behavioral health services and long-term care. So one question, I have several questions, so let me tee them up and then you can answer in whatever order you want. First is, among the various sectors or areas, what do you consider the highest priorities for action? Where is the most serious concern that stuff needs to be done right now, and both in terms of scale and urgency? Second question is, the recommendations, are these recommendations just to policymakers? And an underlying question there is, do we expect these problems to be solved just through legislative or action by the state government? Or are there actions that other stakeholders, other people should be taking? In other words, what is the responsibility of hospitals, physician groups, long-term care facilities, and so on to do this stuff? And health plans and employers in terms of their purchasing strategies. Who are these recommendations to, and what are the expectations from all the stakeholders? I'm hopefully that they'd be aimed at more than just policymakers. So two questions, priorities and targets for the recommendations.
Yeah, thank you very much, Bill, for all your questions. I can respond, try my best to respond, and then my other team members can also jump in and then give some comments. So for the highest priorities, we definitely make a lot of recommendations here, and then there are three that we definitely highlight at the last slide of our presentation, and also highlighted in our report. Number one, we think that some professions definitely need increased compensation. We give some examples, like there are some healthcare workforce, they were underpaid for a long time, and these professions need increased compensation. That will be the number one priority. The number two will be that many professions with unclear career pathways will need better and focused path for increasing their skills, pay, and impact. And another priority I would like to say is that all professions definitely will need more support around the resiliency and their well-being. With that said, I think I can also respond to your second question. So not just the legislative, but this will require collective actions by multiple sectors. For example, we give some discussions in the report that different healthcare organizations, providers, public and private sectors, they all need to work together to create a positive work environment, to improve their workplace cultures. Because resiliency, for example, provider burnout, it depends on a lot of like social, cultural, and organizational factors. So definitely, we agree with you, Bill, that multiple sectors, they need to collaborate to address this problem.
Thank you. That's very helpful. On the first question, I had appreciate the 3 points that were in that conclusion slide.
Yes.
I was asking a slightly different question, which is priorities among the different sectors: primary care, behavioral health, long-term care, oral health, and so on. Which sectors or even subsectors are the highest priorities from your perspective?
So, Irvin, do you want to reply to that? Dr. Jeff?
Go ahead, Jeff, and then I'll go to.
I was going to say that for me, that would be a hard question to answer. I mean, and we were very glad that the report this year was able to include a broader range of sectors than in prior years, and I think the needs are great in many of those sectors. So I think that's from, our goal at OSU was to really try to talk about the situation and evidence in each one. But I think in terms of priorities, I would, ask, this group, OHA, legislators, where resources can be allocated. I think we can support, but for me, it's tough to pick one. Veronica, what are your thoughts?
I would say the same. And I would say that what we saw across many of the sectors was the lack or the need in rural counties across workforce types. And the fact that many of the demographics of many of these workforce sectors did not match the current demographics of Oregonians. So really expanding providers, adding more providers of color, expanding pathways across many, if not all, of the sectors. And so I'm with my colleagues where it was really hard to pinpoint one specific sector, but it seemed like a lot of regions and other areas.
Yeah. Thank you, Jeff. Veronica, there was one more comment that I would like to add. I think Jeff and I, when we met with people from Oregon Center of Nursing, we got a very, very good comment that solving just one sector of the workforce will not solve the problem. Because it is like a domino. If one sector of the healthcare workforce, they got burned out and then they quit, and then all the responsibilities and burdens will transfer to another sector and then another sector. So just solving one, we don't want to prioritize one specific provider types, and we hope to support the overall workforce development.
And Bill, could I speak to your second question a bit?
Sure.
I thank you for asking that, because I thought about that a bit with regard to, especially with regard to nursing and long-term care. Like some of one of the recommendations was about providing more supportive workplaces, and that's an action for employers to take. But I think there's a role for policy to encourage employers to do that, either with financial support or other requirements, and then to hold employers accountable to that. So I think, and then also increasing training. That training is going to be provided by universities and colleges and other organizations. So I think in several cases, there's a role for government to lead and provide guidance, but the heavy lifting is going to be done by healthcare or provider organizations and educational institutions.
Great, thanks.
Kristen.
Thank you. This is really an amazing body of work, and almost I appreciate seeing the words on the paper and the hard work that it represents. It is almost overwhelming to think about how we take steps forward here. And I think that is the crux of the issue for me, that like you highlight, like your recommendations are desperately needed and require some large changes that touch on potentially many. And so I don't want to see it be like, great, okay, this report's approved, done. That is my biggest fear here. So I guess my question, and this extends beyond the authors of this report, but maybe to the agency generally. How do we move forward on making progress on some of these recommendations? And how do we use all the tools in our toolbox to do that? So I think about, you talk about the heavy lifting by employers that it will take, which I think is absolutely right. But when we think about all the various OHA funds that go out, how are we supporting those who need it? How are we incentivizing and rewarding the employers who are taking these steps forward? In a myriad of ways. I guess I'm wondering how much of these recommendations get outside of the box of I am working on health workforce development, and how much it can spread out to other areas so that we have more rewards and incentives. It's a big question, so it can just go unanswered.
We definitely agree with you. I think that's sort of a it's almost a next step question. But I think you frame it really well.
I would just say this, Veronica. I mean, I agree. Some of the recommendations are very much in line within the industry or within an organization. But we felt the need, and we heard from our partners, to identify things such as housing, and to make sure to include that, so that it was in a report, even though it may be out of the scope of some of the work that the agencies do, but that it was really important to highlight some of these needs, so that there's a place to document it. And that we pulled, like, for instance, the housing from interviews that local public health authorities had done, and they had shortages, and one of the reasons was housing. And just so some of them we don't have a clear pathway. The housing is a huge issue, but at least places where it could start to be documented to start really addressing those needs across the states.
Brenda, you've had your hand up.
Yeah, thank you. I mean, I think this is a great place to riff off of the importance and the reminder for all of us around what our healthcare workforce committee work really is about. And so this conversation is very reminiscent to other conversations that I've seen our committee chairs and our OHA staff really lead through, recognizing the complexity of what's in front of us, and then also being very deliberate around creating actionable next steps. So I'm glad, Kirsten, that you raised it the way that you did. And I'm just reminding us that we've, in some ways, really working collaboratively to trust the process that we've put into play to make sure we're giving people the right tools and resources and information they need to do the heavy lifting. So in our packet today, I was really grateful that the committee leadership and staff had prepared a summary letter, kind of sitting on top of today's report to help the committee focus our attention. And that's in your materials already if you don't have it up. The two areas of primary emphasis that I think the committee and others here on the call, I see Laura, can speak to this, is really to improve the diversity of the healthcare workforce itself, to stay vigilant around the pipeline and the development of how to bolster up our diversity framework around the selection and enticements, incentives toward the profession itself. And then, as was mentioned, I think really eloquently by our presenters, the importance of staying focused on resiliency. And without a resilient workforce, it's really hard to attract new people to it. So I really appreciated that orientation. So with that, I know today is a vote, Oscar. I don't know if you'd like me to move forward or and propose that, or if you'd like to, I'm just conscious of time. Yeah.
Yeah, thank you, Brenda. I appreciate that. I actually had a couple, one thought, maybe it's a question. It's actually for you, Brenda. So, and it might be like, maybe it's a little bit of maybe a recap of what you said, but I guess, well, first I see Sandy's hands is up. So let me go to Sandy first, and then I'll come to you, Brenda. So Sandy.
Yeah, just a quick question in regards, you've got A as continue expansion in commercial and publicly funded healthcare coverage. We know Eastern Oregon only has one healthcare provider. So in rural areas such as Eastern Oregon, I think addressing those needs are, critical, because you've only got one shot. You've got one healthcare provider, and you go with what that coverage consists of. Also, I think building your own within your community, because you did discuss housing concerns for providers, but building that capacity with lived experience. I know within our particular organizations, for tribal health, healthcare workers, they know the people, they know the community. And so building and expanding that I think is critical. So when this report is done, is it done geographically about the shortages? Is there more data I can look at where in Eastern Oregon, yes, we have one MCO, a managed care organization. How does that capacity work within that structure for the services provided? And then the number of OHA participants or recipients within that structure that are getting the adequate healthcare needs within that region. Because there's times where we have to, the closest is St. Anthony's here, but then there's capacity of, the overflow going and I guess the quality of work where you have to go outside of the state, go to Walla Walla, Tri-Cities, Portland, other larger facilities. So is that inclusive in some of these reports?
Yes, in our report, we used updated areas of unmet healthcare needs report to summarize those fundings of like the geographically distribution of healthcare providers. So in our report, we summarized the area of unmet healthcare need report, and then we also provided a link there. Then you can find more detail in the Oregon Rural Health website. Thank you, Sandra.
Thank you.
So coming back to the question I was going to ask Brenda, and then we're going to hear from Laura, the chair of the Healthcare Workforce Committee, right after that as well. But so as I was, navigating through the 100+ page report and, reading the multiple reports and attending the webinar, I was like really, kind of wondering about sort of your experience and even like capacity as the board liaison in this very heavy, big topic, right? That is so important. And as I was reading the report, there's also so many references to like, oh, and OHPB is in charge of this. Oh, and OHPB is responsible for this. Oh, and OHPB is like supposed to be leading this. So, and, this also is in connection to our conversations we hope to have this year about, board priorities. So I don't know if that's necessarily like a question, but I just love to hear your thoughts, Brenda, about your experience as a liaison as it involves, this very big body of work.
Yeah, thank you for that, Oscar. I remain incredibly impressed by the people that are doing this heavy lifting work. I have the privilege of sitting in on the committee conversations and to a person, what our committees are, how they're really wrestling with the complexity of the challenges that we're talking about today is quite impressive. So I invite all board members to hang out in the Healthcare Workforce Committee. Anyway, I'm biased. I would also say that in terms of it's easy to get lost in the weeds if we don't keep our focus on on what matters the most. And I think as a committee, we struggle from time to time, similar in today's call, with, hey, what about, hey, what about, hey, what about? And I think the board leadership, our committee leadership is really challenged to really to keep us focused and on track. So we talked about different parts of the workforce that have different personal interests for people. Oral health often gets lost behind, or this part of the system gets lost behind. And so the committee has to be thinking comprehensively across all disciplines. And I think does a really great job balancing exactly that. Last comment, and then I hope, Laura, you will share a little bit about your reflections as leading that big body of work, but it's mostly to suggest that we must, as a board, stay vigilant on it in this year. This data, if it sits on a shelf, and this importance of this body of work, from my perspective, I cannot imagine a situation where this wouldn't sustain, we as a group wouldn't think that this is one of our most critical priorities for the policy board to stay focused and attentive toward. So Laura, what else am I missing, please?
No, thank you, Brenda. Chair Arana and committee members, thank you for allowing me just to take 2 minutes just to talk about this report and the letter. My name is Laura McKean. I serve as the Director of Oral Health Services for All Care CCO. And I've had the privilege of sitting on this committee for 6 years, and this past year chairing this Healthcare Workforce Committee, which has been some of the most rewarding work that I myself have ever done. And in the report, you can see, as Brenda said, there's a lot of data. There's a lot of recommendations. I think, as Brenda also said, 2 of the things that stood out for us was improving the diversity of the healthcare workforce that we have, and also enhancing the resiliency and well-being of our workforce. And I don't think without addressing these 2 areas of work, we can't really focus on the other areas. So that was really important to us. And also, we're going to look over the next year about how we can take several of these recommendations and develop plans, just as Kirsten said, this is a huge body of work. I don't think we're quite sure how we're going to undertake it, but we have a plan to move forward and tackle it. And, we want to just hopefully think outside the box. There's a lot of barriers for folks to come to work, such as childcare. If you don't have childcare, you can't go to work and do your job. That's a huge issue all over the state. But really, I feel that our healthcare workforce is the heart of our healthcare system. And, we've seen in this data that professional types in our healthcare need more compensation, and they need more support, and they need focused career pathways that are going to elevate their skills and impact, and all the time supporting, again, the resiliency, and give them the opportunity to practice in environments that support their well-being. So as a committee, we are committed to being part of helping Oregon move forward to a better future. We are thankful again for the team at OSU that worked on this report. And again, thank you for letting us come to present today. And we look forward to the continued partnership as the Healthcare Workforce Committee. So thank you.
All right, well, thank you, Laura. Any other comments or questions? And we'll hand it back over to you, Brenda, to make that motion.
Sure. The motion is to approve the Healthcare Workforce Needs Assessment Report. There are a few pieces of details that'll be packaged together prior to the report to the legislature on February 1st. So move to approve.
Great, thank you.
I second. This is Ebony.
Thank you, Ebony. Any other discussion? All right, all those in favor, please say aye. Aye.
Aye.
Anyone opposed? Any abstentions? All right, well, congratulations to the OSU team and the Healthcare Workforce Committee for the unanimous approval of your report. Thank you so much for all your great work in this area.
Thank you very much.
All right, and our final presentation today is going to be inviting back Dave Inbody, the OHA CCO Operations Director, who's got an update for us regarding CCO 2025 contracting and the report that went to the state legislature at the end of December. Dave, take it away.
Thank you. And I'll try and limit my presentation. I'd really like to leave enough space for discussion and questions. But just to give you a refresher, the request from the legislature as part of our OHA budget submission or budget bill in 2021 was to return by the end of 2022 with a report that kind of outlined some of the high-level milestones and timeline for the next procurement process for the CCO contract, and also to outline some of the components of the process that would provide public transparency and communication, and then finally some of the anticipated resources needed. You can go to the next slide, please. Actually, you could probably jump to the next slide. One of the things that I wanted to stress, and I know that we've addressed this in previous meetings, is just the idea of being aware of where we've been and taking into account what's already come to pass and utilize that as best we can in the next procurement process. You know, the initial idea in establishing the CCOs was to ensure that there's integration and coordination of benefits and services, and that there's local accountability for the health and resource allocation, standards for safe and effective care, and then the idea of a global Medicaid budget that's tied to sustainable rates of growth. With the CCO 2.0, the governor had provided 4 focus areas for that contract, and there was a lot of emphasis on the policy and then the accountability for those policies. The governor's focus was in the areas of social determinants of health and health equity, the value-based payments and pay for performance, improvements in the behavioral health system, and then maintaining sustainable cost growth. And through that, the Oregon Health Policy Board had established 43 policy recommendations, of which were used as the point of development for the contract, as well as in building out over 200 different CCO contractual requirements. Next slide, please. So some of the considerations in moving forward with the next contractual period was to emphasize and to work through a perspective focused on our 2030 health equity goal of eliminating health inequities. Recognizing that the next contract, which would run from 2025 to 2029, would be key in whether we were able to pursue that goal successfully or not. And so ensuring that that's a lens that we'll be looking at the contract through in all aspects. Building on the existing priorities and structures, not looking to start over, but instead to look at what we've done so far. What are the places where we've been successful, and how can we support that? And the places where we may not have been as successful, what changes or adjustments need to be made or refocused to ensure that we're able to be successful in those areas, or more successful. The other was also to take into account the other concurrent initiatives that are going on at the same time, recognizing that we're working through the 1115 waiver implementation in the coming year, as well as the public health emergency unwinding and the associated member redetermination, the establishment of the bridge plan and the basic health plan over the course of the next year and a half. And then any potential changes to the Healthier Oregon program, which was established last year, and the expansion of that non-Medicaid component of the contract we have with the CCOs. And another piece is the leveraging of the current CCO performance for evaluation. Look at what we've done so far, and look at it not just from how have the CCOs performed in addressing the requirements within the contract, but how has OHA done in providing the oversight and the guidance in addressing those particular components of the contract. And then the other key is elevating the role that the members, the community, and the external partners will play in a collaborative decision-making process, and what that might look like. The idea that it isn't, a one pass with external partners and external key members, key participants, is that we provide the opportunity for multiple points of contact and the ability to be involved throughout the process. And then finally, still the part that is unknown at this point is what priorities might the governor or the legislature identify critical or for this particular contract. Next slide, please. So some of the focus areas and what was highlighted in the report, which I think was provided to you, there's really three very specific areas that I think are going to be key in making this successful. And they highlight some of what was asked for in the report. The first being the project management component is ensuring we have key project management in place to work through this process and make sure that it's a clear and clean process. So a project plan and the associated responsibilities of that plan. The second is as it relates to the engagement and outreach plan, to have a very distinct and specific engagement and outreach plan and how we're going to include members of the community in that process and what that looks like in terms of the actual decision making associated with the development of the next procurement process. And the third is the communications plan, making sure that we have a communication plan that focuses not just internally but externally and ensures that all of those that are directly and indirectly involved in this process maintain a clear understanding of where we are and what's going on in the process and where the priorities sit. And then taking all of those into account, the other component is the actual implementation plan, making sure that we have the people in place to make this work. And part of it, and the way that we are hoping to address this, is to leverage many of the efforts that are already underway, whether it be through any of those larger projects that are going on at the same time, or the efforts that are currently underway in particular areas as it relates to particular components of the contract. Next slide, please. So just to give you a review of some of the initial steps that we've taken along this path thus far. So we presented the initial concepts to the CCO CEOs in mid-November. And then I was here last month to talk about the concepts with this board. We submitted the legislative report at the end of the year. This morning, I presented to the CCO Operations Collaborative, and then coming to the meeting here today, with the idea that over the next month or month and a half, what we'd like to accomplish is to engage the new OHA director, as he mentioned this morning. This is day one, so giving me a chance to actually take his coat off before we start inundating him with questions, but recognizing that he's going to have input on where we go with this process. And then what I'd really like to talk about and maybe start that discussion today is what role is key for this board to play moving forward. I think the one thing that is clear is with the changes that we've had, both governor and legislature, as well as in OHA itself, I think it's important to ensure that we have the insight and the input of OHPB in this process. Because part of it, at least from my perspective, is I think that you have a good perspective on where we've been and a good perspective on where we could go. And I would really like to partner with you in developing potentially recommendations on what that might look like. And as part of that process, I would like to, within the next month and a half, be able to provide a recommendation to the governor in terms of exactly what this looks like. But with that in mind, like I said, I really am very interested in the comments and the questions from this group, and would open that up for discussion at this point.
Thank you so much, Dave, for your presentation and for submitting that report. Sandy, you have a question or a comment?
Yes, based off your mid-review report, you stated that 58% of OHB's 43 recommendations have been fully implemented or on track to be met. So can you break that? Is that broken down somewhere where, even though what of the 43 recommendations, I guess, have been achieved through the CCO? I know the pandemic put a hold on some of CCO requirements. So with that said, you're wanting support with the what is it, 23 through 29. For some of those requirements for CCOs, I guess those achievable or partially achieved recommendations. We've been doing this since 2011, and I was involved in that at the very beginning with care coordination organizations. So, and it's kind of changed over the years with more strategic plans, more accountability and transparency through CCO. So I guess with that said, where do I find that information to justify, going forward?
Yeah, and thank you for the question. Chris DeMars and I had presented to this group in November on a more detailed breakdown, and I can provide that information. We had both, the slides walk through kind of a summary of those areas where we performed better or worse, and also a tracking tool that walked through each of the 43 recommendations and basically provided some indication of where we are in light of each of those. And I can make sure that gets redistributed, because I think that's a good place to see a lot of what you're asking is how are we performing, individually against some of those original recommendations.
Thank you.
Thank you. Yeah, I'm reading it right now. Thank you.
John.
Yeah, thanks, Dave. As I think about your question, what role should we play? and think about, 5 years ago, when we got involved in 2.0. And I don't think then there was a clear-cut process for OHPB involvement in CCOs. But, it started with the governor telling us what her objectives were. Then we had, we were part of a very significant outreach in a variety of ways, and meetings, throughout the state and things of that sort. That was a really significant and rewarding effort for me, at least, as a relatively new member of OHPB then. We had significant discussions at the board, and developed the priorities that those spreadsheets that you and Chris worked up, were developed from that. And at least for me, I think that worked pretty well. And when I looked at those spreadsheets, I could see how it was great some of those got done. I could see how some of them were probably pretty difficult in terms of COVID and all. But I could see that, you all hadn't forgotten them. And, you were thinking about how to move, forward. I suppose the piece that's kind of missing is, a sense from the CCOs. And I know I recall some meetings where the CCOs came and we talked, and I recall learning a lot, from those. But that piece, I think is hard to do on an ongoing basis. So you'd have to think about that, because we don't have really direct lines to feedback from the CCOs and all. But so I just wanted to put a word in. I personally think the process we used in 2.0 worked pretty well, and we should start there and improve it, and all. Thanks for your hard work. You have a hard job.
Yeah, I appreciate that. And I can say that the recommendations that were provided last time have been a really helpful tool. I mean, kind of keeps us on track of saying, this is what we were looking at for 2.0 at the beginning. And are we still focused in the direction that was intended? So I see those as something that we're able to reference throughout the process. It's been really helpful. I think the one thing that's challenging about this time around that's different than 2.0 is we had a sitting governor at the time that was able to provide that direction. And although we have a governor that is probably well informed about many of the things that we deal with, she is new to her position. And I guess part of what I'm trying to get a sense is if there might be value in the policy board providing at least some initial suggestions in terms of where a structure in terms of where we may want to focus our attention moving forward, instead of the ask that we seek her to provide something with a blank slate. That maybe there is some of what you've learned over the last several years, or the perspectives that you can provide in having gone through this once already, that we might want to take into account before stepping forward on the next round.
I definitely like that suggestion, Dave, and would love to hear from others as well. So maybe we can keep going on answering your question. From any other thoughts from other folks around the role they'd like to see the board play in this process? Brenda.
Yeah, I mean, I think it's been already well articulated. I would suggest that we have a responsibility to take an active role, and that we create agendas that keep it current in our awareness. I think, our board's capacity to handle substantive work over time usually proposes that we have updates in our cadence that's mapped out throughout the calendar year in a way that is digestible for us. And then, of course, just incumbent on us as individuals to read the great work that the team prepares for us, so that we can come ready for, really to contribute in a very meaningful way. And to that end, Dave, thank you. Your summary report was really great, but I really found a great deal of value in the more detailed reports that you've been providing as well. So I just wanted to reinforce that the narrative is also as much, as helpful as the details within it. So thank you for that. Yeah.
Thank you, Brenda. Ebony, your hand is up.
And this is just more of a comment. So kind of to ditto to what Brenda spoke to. And I found myself reflecting back on when I first started on the board, and, there in some arenas seemed to be a narrative, and I'm just saying quotation marks, a narrative that the board, it wasn't clear what the board's role was from some folks' perspective. And so I think that, just as Brenda said, this would be one of the great many opportunities to really kind of, to lean in, be visible, and continue to be, proactive in kind of where we sit with our role and scope. So more of just a thought that popped into my mind.
Thank you, Ebony. So I agree. Oh, and Trilby, you have your hand up. Go for it.
Yeah, and I'm happy to wait, Oscar, until after all the board members have spoken, but I had just a thought on process to add at the end here. So please go ahead if you had more to say on it.
Sure, maybe I'll make a comment and see if it spurs more board conversation, and then we'll go to
Absolutely.
you. So Dave, I thought the report was very helpful, kind of like Brenda said as well, that it took me down a little bit of like the context, right? It took me down memory lane of previous board meetings. And then finally we got to like present day and, next 6 months plus year or so, and even more. So I really like the context. I really want more information on the next year to 2 years to get us to 2025. There was one big question that I'm not even sure how to answer that question. And it's an important one, but it's around like whether we're going to allow for more competition in the next contracting process. What I read from the report is that you know, it's very likely that we just say the current CCOs are it. And maybe there's a lot of good reasons for that decision, but I always get a little bit nervous when there's no competition, there's no innovation. You know, there's an opportunity there. We miss innovation. Like when so many folks are not feeling like they have to compete, definitely we miss a little bit of like trying to improve is my opinion. So I don't know. And then there was another option of like potentially maybe just limiting it to, you know, certain, like not allowing certain types of new entities, you know, like, and I wanted to hear more about what that other one is about. So I'm wondering if you could speak to just that in general.
Yeah, thank you. I appreciate you bringing that up. Yeah, it is an interesting balance, because I heard some very strong opinions on both sides of that. You know, on the one hand, we don't want to start from scratch, because I think there's been a lot of work done with the existing CCOs to get us where we are, and in developing and understanding what the intent of the current contract is and where we'd like to go. And I know they've invested a lot in trying to get to the place that they're at now. But by the same token, the points that you make are valid as well. We don't necessarily want a strictly closed application process, in that it limits the abilities for or opportunities to grow and to expand or to see things in different ways. I think part of the idea that we want to work through, and this is again a place where I think it's very important to get this board's perspective as well, is what do we want this to look like? I mean, do we feel like we're moving in the right direction in the way that we've structured it, and it goes kind of beyond that question of just those that are players today. Do we just include them, or do we expand it? But there's also the organizational consideration as well. I mean, when you look at the CCOs, they're developed very differently, and I think part of that is because of the communities that they represent has lend themselves to developing in these different ways. But also consideration that should be taken is the development. These differences in development have also led to strengths and weaknesses in CCOs themselves. You know, there are some that, because they were developed more community in an outward manner, then you see a lot of the connections with community that are already there. And so the lift for a lot of the community engagement work was much easier for those CCOs than it was for those that were coming from outside. But by the same token, we've seen some of the larger organizations that are more oriented around managing plans as tending to be more effective in the administrative oversight work than some of the smaller ones that were newly developed as part of this process. And so some of those discussions I think are worth having as well, is what do we, and it was part of the reason why I included those initial considerations. When we're putting the CCOs together, this is what we had in mind. Do those still fit? Are they still valid? And when you look at the CCOs, do you see that in them, those original intentions? When you have a vision of what a CCO should be and would be in order to address the needs of the members, are we truly representing that in the current form, or is there a need to make adjustments there? So I think that's part of it too, is not just the organizations that are participating or not participating, but how they're participating and what that looks like in terms of organizationally how they're engaging the community, and whether that's we're doing it in the way that we want to, and it's in honoring the expectations when we had originally conceived of the idea of a CCO. And that's where I think it would be helpful to have the board's perspective on that as well. Because I think that's a pretty broad and challenging question, but I think it's an important one as we move forward.
John.
Well, as I listened to Dave, I just thought it's very interesting to me, the pros and cons of a competitive model versus a cooperative model. And it's also, I completely agree with you, one of our big problems in health is variation. And our inability to, in some cases, identify it, and then in other cases, to do something about it when it's obvious or it's clearly an issue. for me, I've got to admit that if there's a CCO who's clearly in their community, who's clearly making progress on meeting, the objectives, and the delivery system in that community is working with them and is satisfied, and the community is working with them. I personally, I'm not sure that competition is needed for a next contract there. I know that can be difficult for some people to accept, but that's how I would feel. On the other hand, if a CCO isn't performing in critical areas, then opening the opportunity in that CCO's area would be appropriate, with an emphasis that here are the things that you're falling short in. And I'm a believer, and it's hard for some people to accept this, but you can't have quality without standardization. And I know the CCOs always say, well, if you've seen one CCO, you've seen one CCO. I don't buy that. I think that many of them are succeeding because of the strategies that are likely more similar and common than they think, and they're sharing those, et cetera, et cetera. So, but that's a good discussion to have, I think.
Thank you, John, for those comments. I guess this kind of goes back to maybe even Sandy's question about, sort of the previous information that was presented to the board in November about what things have been met and what hasn't been met and what's still outstanding. And I wonder if, that's all been consolidated. I wonder if we can sort of drill down to kind of have a better understanding of what John is saying, of which CCOs probably need more attention, and what areas need more attention.
Yeah, I totally agree. I also think it's fair to look at OHA's role in that as well. I mean, one thing that we did learn through CCO 2.0 is there were a couple of areas where conceptually we thought, this is the way that would be best for reviewing and providing oversight for particular requirements, only to find out that, well, we really didn't get the information that makes sense, or this is the burdensome efforts on the part of the CCO and OHA just to get this completed wasn't worth what came out the other end. And so part of it is working through some of that as well. Are we asking for the right things? Are we doing it in a way that isn't inhibiting the ability to provide service, but at the same time that we're getting good value out of the information that we receive, so that we get a real sense of how we're performing against the requirements of the contract.
Let's go to Trilby, and then we'll see if there's any other board questions or comments.
Okay, thank you, Oscar. And Dave, thank you so much for this presentation, and you're approaching this in such a thoughtful and detail-oriented way. It's really valuable, I think, to be bringing this information forward to the board, and really appreciative of how everybody's digging in with questions and thoughts. I'm going to back us up a moment just to more of a 50,000-foot level for a moment, and just think about, sort of the buckets of comments that we're hearing from you all. We're hearing a lot of interest in what have the outcomes been, and how do we take a look back, as Oscar said, dive more into what the recommendations were last time around and how well the system has been performing against some of those goals that we set. So that's definitely something that we'd like to hear more from you on. If there are members here who are interested in doing more discussion of that. And then the other piece that's really surfacing is around the process. As we go into a procurement or, a major contract with CCOs, there's interest in how competitive should it be? Are there areas where we could be more cooperative in the state? Would state procurement rules allow for a blend of approach on that? And how much do we want to standardize, what we're expecting from CCOs in terms of structure and reporting and some of these tasks that Dave mentioned have seen some real variance in the CCO's ability to wrap their arms around them. So I think there's just some real promising discussion here. And what I wanted to offer up is we're going to need to get a briefing ready for the governor. Dave's going to be working on that, thinking probably in February, there'll be a briefing on the procurement process and decisions that need to be made on that. Because believe it or not, we're already behind schedule. I mean, this is something that really has to be, initiated and launched now. So would this group be interested in coming back for another meeting? We've picked a date and Tara can tell us the exact date in the next month or so, where we can pull together some of what we've been hearing, give you more of a summary of where we stand on the board's priorities from last time around. I know Dave's been working on that, and see if we can solidify some of this input so that it can be part of what we bring forward to the governor. And then if you all decide that you want to formalize that into some recommendations for a more formal communication to the governor, that's great as well. Speaking to your role, speaking to any high-level guidance you have on both the process for the procurement and the priorities that the agency should look at. So I hope that makes some sense. Just offering that up as a next step forward, given where we are in the timeline on things.
Thank you, Trilby. Those are good suggestions and thoughts. Let's go to Melina really quick.
Thank you. I like the high level overview. I was looking and reviewing the 2.0. I don't have a lot of history on the board, but I'm starting to develop more. And there are a lot of items that were not met. And I think a lot of them are very important, such as the behavioral health items. And so, yes, I think that it would be wonderful to go back, look at the ones that were not met, prioritize those, and assist with the report to the governor.
Great, thank you, Melina. Brenda.
Thank you. It's a similar vein of thinking. I'd like to consider the things that are still priority, but recognizing that we're in a very different state, than we were at the time that we created those priorities for 2.0. So the flexibility, I think, as a group of recognizing, I can't say this without having recognized the last conversation about workforce and talking about the chain of events that happen as we set priority, we push this initiative or efforts into CCOs, into the delivery system itself, and how we balance its capacity to be able to deliver on even our brightest, our most insightful thoughts. And so in balance, I agree. I think, Trilby, to your suggestion, the question for me is about not just one meeting, but if you all can help tee up the most critical directional setting kind of guidance questions that you have, so less in the weeds of did we or did we not do the one specific, like item 43.B, but more like, this question of service area competition, the questions around sort of where impact on workforce. I could name a couple major themes, that we would want to say, how do we actually think about it differently? So that's my feedback. And I appreciate the timeline between now and the summer. So again, to you, Oscar, kind of creating a cadence by which we can invite these bigger questions, have some time on our agendas to really explore them, get the prep work from the team in advance so that we can engage it thoughtfully. Yeah.
Thank you, Brenda. Dave, I think this is also a resource question, right? And I think part of that report was actually putting out like some resources that the agency will need to be able to execute the work. I'm kind of curious to hear if you have an idea of like when some of these, like when are these resources approved and when do they start coming into play so that you have additional capacity to sort of carry this work?
Yeah, and this is part of the I had alluded to the fact that we want to try and leverage some of the existing resources for some of this work. There's particular places where I think it's going to be key to have committed resources. One being project management, which we've dedicated existing staff now to that work. So we do have committed project management already. we've highlighted both the communications and community engagement resources. Initially, I think that's probably going to need to grow over time, but I think we have the resources to start the process. I think if you're open to the suggestion that Trilby had made, we can pull together some of those initial questions or discussion points for a meeting later this month, maybe as a starting point to see kind of where we go from here in preparation for the providing recommendations to the governor next month, or in a month or so.
Yeah. Yes, definitely interested in Trilby's recommendations, and even following up on your suggestion, Dave, to try to like get the board to sort of outline this, get to the point where we can outline some high level priorities for us as well on procurement priorities for 2025. Other thoughts, questions, comments on this? All right, sounds like, oh, there we go, John.
I just thought it would be really helpful to have that higher level, as Brenda mentioned. For example, I recall we really prioritize children. And I would be surprised if this governor wouldn't prioritize children, looking at the waiver and the continuous coverage that it provides for children. But I think it would be nice to see whether that area is still important to the board. Because in some respects it's almost like, hey, we've done so much there that maybe it doesn't rise like it did before, but I think it still should be a high priority. So anyway, very thoughtful discussion.
Thank you, John. Any other thoughts? All right, well, this was
I just have a quick comment.
Mm-hmm.
So, I don't know if when the new governor is going to actually present her budget. But with that said, is there any guidance through some of the processes for, this transition with Medicaid, and also moving on into the people switching over, maybe the 140,000 people that may switch over to a different a future healthcare system. And when you look at that, whether it's the Oregon Health Authority, with that decline in membership, is that being actually included in some of the predictions of capacity for these CCOs? It may go down. It may actually open it up to the marketplace exchange and still having that same, same service area delivery system for those CCOs in a different capacity of insurance viability. So when will we know, at our next meeting, will we know more information on, Gabe, as discussions occur with the new governor's office?
Well, what we're trying to plan for is to provide recommendations by the middle of February. So I don't know that we'll necessarily have it by the next meeting, but again, that was part of where I think it'll be helpful to have an in-depth discussion with the board about potential areas of interest or focus moving forward that we can then provide as part of those recommendations to the governor.
So
but to your point,
go ahead.
I'm sorry, go ahead.
Oh, no, I was just going to say, you had three components identified, milestones and deadlines, public transparency and communications, and the needed resources. So how did you identify those essential components? And what were they?
Yeah, that's what was incorporated into the report that we submitted to the legislature. And I think mainly the milestones and timeline is broad at this point, but trying to emphasize a couple of key areas, being ensuring that we had strong project management in place and a focus on the communications component and the community engagement component, which then speaks to the public transparency and communication request, and then also the anticipated resources. Again, those are the three areas where we're focused on, with the idea that the policy components of the contract, we can leverage existing resources. And to that point, you know, the other projects that are going on at the same time, for example, the waiver implementation, we're going to be focused on many areas that would then be incorporated into the contract. So we wouldn't necessarily need additional resources, but we could leverage the existing resources in the waiver. And to the point that you had made about the potential for the basic health plan, does that mean that the CCOs need greater capacity because they'll now be responsible for this additional component of this additional plan that would potentially expand their responsibilities, or is it something that they wouldn't necessarily see expansion, and there'd be a reduction from their existing number because of the end of the public health emergency? So I think some of those questions are a broader part of this to take into account as we move forward. But the idea being that at least from our perspective, where we really want to focus is to ensure that we have the project management, the communication, and the community engagement components of resources to do this work, because that's what we need at this point in the process.
Right. Thank you so much. Sandy, did you have anything else?
I'm sorry, I just want to say thank you. And I guess one other thing is health equity and how that plays into this bigger picture. You know, that's another 2030 objective. So just curious.
Yeah, I think everything we do for this next contract needs to be looked at through that lens. Are we moving forward? Are we getting closer to addressing the needs as it relates to health inequities through this contract, or are we not? And I think running that through as a consideration as we develop the contract is going to be key.
Thank you. I'm sorry about that.
Okay, we're at time, and I think we had a good discussion from the board and some thoughts and some good direction on next steps. Tara, Trilby, Dave, and the board leadership will follow up with the board on some of these additional next steps regarding another dedicated meeting to talk more about this, and definitely hear you, Brenda, about the cadence of ongoing conversations over the next year or so as we work through this very important project. So if Ebony is still on, I hope we get to see you at the February board meeting as well as a fellow board member, Ebony. If not, we'll definitely be seeing you in future meetings. So thank you so much for all your work, and yeah, have a good rest of the day, everyone. Take care.